I'm going to give you a list of all the things you should have in the pharmacology course, okay? Everything that goes on with female reproduction. Now, I promise not to go through all that tonight. They've asked me more to concentrate on the hormonal ones. And I give you the rest of that list because we will cover it this end of this spring into the summer session, so that you'll find little niches where these drugs come up. And if you want to, you can go back and take a look at the little summary slide on the drug itself, so you can see the highlights of the pharmacology, as well as the clinical aspects of it. So I'm retired, okay? And in retirement, you get to do what you like to do, and this is one of the things I like to do. So I get to work with you once a week, and I put together a little team where we do women's care. And it's 4 hours. Every Monday morning, we're going to have a chance to meet. Hopefully, it'll be as interactive as possible. But this is sort of a little preview where we stuff a whole bunch of stuff in. Now, in order for you to understand hormonal therapies for women, you're going to have to understand a little bit about the menstrual cycle. I'm not going to go into great detail about that. That's for really the repro course, but it isn't going to make a lot of sense unless you know how hormones work in a woman's body normally, and then you can see what the medications might do. Does that make some sense?
Yes.
Okay, but please, I'm not going to ask you details about the menstrual cycle now. I will later on, okay, because that's sort of the lightning rod, that's the decoder ring for a lot of women's care. If you don't understand the menstrual cycle, and I promise you, it's nowhere near as complicated as the clotting factor of Cascade or the Krebs cycle, okay? And once you get that aha moment of how the pieces fit together, it really is almost trivial, okay? But if you don't understand it, then you can make a lot of clinical mistakes, okay? And I don't want you to do that. So we will drill on it, okay, we'll go over it, and then we'll exercise it when we get to it. But today we will probably do the 7,000 foot level. So don't expect yourself to know a whole bunch of details, but how it all fits together, I would like you to know. Okay, so we'll play a little bit with it, but not extensively. Okay, I do work with industry quite a lot, and I do an awful lot of research. I think any company that's willing to go into women's care these days and come up with products, yay. And most of those companies you've never even heard of because they're little tiny startup companies. Most big industrial companies are no longer interested in getting involved, particularly in contraception. There's just not enough of a return for them, so they'll bail on this. So if you have any questions about that. The syllabus lists all the, I just didn't want to write all of this out. Is that okay? Being lazy, okay. All right. So this is what we're going to do. We're going to look at the hormones that are produced during the menstrual cycle, and we're going to look at what their impacts are on each of the reproductive elements of the reproductive system. And then I want us to take a step backwards and understand what their impact is on the rest of the body. Okay, and this is only women, right? I'm an OBGYN, and I don't know what those things are, what they're good for, but they're a lot of fun. And then what we're going to do is, I thought, rather than start with reproductive years and talk about contraception, because that's a little more complicated, I'd say, what happens if she doesn't have estrogen, right? You go into the menopause. And then what would be the treatments for the symptoms in menopause, and what do we know about those? And then move on. My hope is to go into progestin-only methods for contraception, and then layering in the estrogen. And I think that's kind of a logical progression, that it might make it easier for you to understand. And then you can come back in any way otherwise. Now, so that would be symptoms of menopause. What do we have? Drugs to protect against pregnancy. Then there are all these drugs that we have, and oftentimes they overlap. You'll see that they'll have an application in contraception, but they're also very good for all these other little things. Sometimes they're on label, and sometimes they're just our best evidence-based. And then there's sometimes, gee whiz, that'd be a good idea. We will not teach you the gee whiz, it sounds like a good idea stuff. So menstrual-related problems, that could certainly be heavy bleeding, it could be PMS, it could be PMDD, it could be catamenial problems that she has. Drugs that are used to interrupt pregnancy or to sustain it. Both of those are sort of parallels. And then drugs that we use to treat infertility, too much bleeding, too little, too infrequent, cosmetic problems that are caused by imbalance in reproductive hormones, and that would probably be mostly androgens, wouldn't it? Because women don't, well, they do complain about some of the estrogens. We'll talk about that. And then drugs used to prevent hormone-sensitive conditions. Women suffer an awful lot from endometriosis, adenomyosis, and fibroids. And then we get to the cancers, right? We have a whole set of drugs that we use to prevent these cancers because they're hormonally sensitive, and to treat them when they do come up, okay? So that's kind of an overview. Then we're going to cover later on drugs that we should use before pregnancy to prevent birth defects. Don't you think that would be a pretty important thing, okay, to know about? And then drugs that we use to treat common problems in pregnancy, right? And then we now, thank goodness, for the last couple of years, finally have things that reduce the risk of some of the most serious pregnancy complications, preterm delivery and preeclampsia, eclampsia. We have ways of reducing the risks for that in high-risk women. And as women get close to delivery, if they have a preterm delivery, how can we protect the fetus? We have drugs that will stop labor and maybe give them neuroprotection. And then we have drugs that will induce labor. And then, of course, another very large cause of maternal mortality is postpartum. And we have drugs just to stop the bleeding, right? And to be able to have drugs that stop the bleeding in developing countries has made such a huge difference in maternal mortality. Okay, now, the reason why am I talking to you? Are you all going to be OBGYNs? No, right? But do we all want you to be interested in women's care and then understand the impacts? It was strictly primary care. You're going to send everybody, you know, with a uterus, you know, to deal with OBGYNs off to a GYN. That's not going to happen. You know that. You're going to have a well-rounded service. But even when you're not in the world of OBGYN, there's some important things you have to think about. Say you have that teenager and you're going to start her on, what am I thinking about? Exactly. She is a teratogen, isn't it? And if we've got somebody with a seizure disorder, those drugs cause birth defects, right? So you're thinking of all the drugs that you might use in your just everyday practice. You've got to think about this woman as, and you hate to think of it, but a ticking fertility time bomb, right? What would happen if? And I'm not saying that you wouldn't use those. Of course you would use the drugs, but you'd also complement it and make sure she was using a contraceptive. And you wouldn't say, oh, you need to go to your gynecologist because you're starting the drug today, yes? And it's on us at least to build a bridge over to something that might be even more effective. Now, let's open the Pandora's box and make her pregnant. My gosh, all the drugs that you have to think about and how pregnancy may change the doses you need to use. And before she gets pregnant, if you're not taking care of women who are pregnant, if a woman is thinking about becoming pregnant, what can you do about the drugs that might have teratogenic impacts? You may not be able to stop them. You can't stop an anti-epileptic drug, right? Cannot. If she's thinking about pregnancy, unless she's had the 2 years off, that kind of stuff. But could you wean her down to a lower dose? Because many of these adverse impacts are dose related. So here you are in the perfect position to talk to the woman about what she needs to do to get ready for pregnancy, and you can do everything that you can to think about the medication she's on. And then ask yourself, is the drug going to cross the placenta, and what's the impact going to be on the fetus? And in pregnancy, we have to change the dosing that we would give to the mom for a lot of the drugs so that we can treat the fetus, right? Make sure that the administration is right. All right, so what are some of the common hormonal agents that we're going to talk about? And the categories here are estrogen, anti-estrogens, progestins, and antiprogestins, and then antifolic acid, right? Androgens and anti-androgens, okay? And in each of those, we'll have different categories of drugs that we'll use, and so that's just sort of a checklist, but we'll come to them. Then other things to treat PMS and PMDD, the cutaneous problems, controlled bleeding, all of those we kind of covered, and I'm giving you some names to put into those slots at this point. Not that we're going to cover all of them, but it's interesting, there's this one drug that we use, and some of you, how many of you have worked labor and delivery? Or shadowed there or something, been a patient, okay, something like that. Okay, there is this drug we have called magnesium sulfate, and we run it in IV. And my gosh, we use that drug to reduce the chances that she'll have a clinically apparent seizure when she has preeclampsia. We use it to arrest preterm labor. And most recently, we've discovered if we administer it to mom before she delivers a preemie, it'll help with the CNS problems that that little baby might have. So neural protection might be there. And that's really quite a robust little drug when you stop and think about it. But sometimes its two purposes may interfere with each other. All right, so what do we need to cover? Mechanisms of action, routes of administration, what would be the indications on label, and then by evidence. The most common adverse events that you need to worry about. I don't get too much into nutrient drug as much as drug. Okay, and in the drugs I'm talking about, there really aren't that many nutrients that you have to consider, but if you bump into some, let me know. What would be contraindications, right? Relative and absolute. And then the doses, we talked about impacts on pregnancies, and then the therapeutic range, and I think more importantly here, monitoring principles. In endocrinology, we're so used to starting a drug, looking for a response, right? Measuring response. Have you guys done thyroid yet?
Yes.
Okay, so you know, if she's hypothyroid and you start her on a replacement, when do you measure her next? Do you see her next to measure her response? Is it going to be tomorrow?
No.
Next week? 6 weeks?
No.
6 weeks. It's going to be that long, right? Okay. And I'll take in hormones. It's totally different. Okay? We don't measure anything. All right, let's wake you up. Which of the following hormones is produced by a woman in the greatest quantity every single day during her reproductive years? Is it estrogens, progesterone, or androgens?
Androgens.
Oh, you guys are smart. Where did you learn that? That truly, okay. This helps me know where you're starting from. Most people would say estrogen, wouldn't they? Because that's sort of the defining, okay? But we do know that it's androgens, and by an overwhelming amount. Adrenal production, we know that the adrenal glands make an array of androgens, don't they? Right? And we think about half of testosterone comes from the adrenal glands, half comes from the ovary. Now, when you're talking about dihydroepiandrosterone sulfate, okay, 90% comes from the adrenal gland and 10% comes from the ovary. So when you're trying to pinpoint where the tumor is that's making the excess, you look what type of androgen is being produced, and then you know which organ to survey. So clearly, does this all make sense to you? Is this ringing, or were you just reading one slide ahead of me? Reading a slide ahead of me. Okay, that's very clever too. That kept you from getting it wrong. Well, no surprises here. That's good. And that is important to realize. So think androgens, and maybe 100-fold higher. Now, why is it that androgens are such high numbers that women look the way they look and have this strong estrogen effect? Well, because a lot of those androgens are converted into estrogens. And where they convert and how they do it is very important, particularly in menopause. So they are the substrates that cells use to make estrogen by aromatization. So it's cyclic aromatization that they talk about. And that happens, right, in the ovary. And very carefully, there's a set of cells on the outside of the follicle that takes cholesterol and makes androgens. Okay, so those would be okay, I'll think of it in a second. And then those androgens then go into the inner ring where the granulosa cells will convert that androgen into an estrogen. And it then goes into the follicle and out into the circulation. Now, what you want to know, what kind of estrogen is it? This is the natural estrogen. The ovary is the only organ that makes estradiol. Okay, estradiol comes from the ovary. Everywhere else, the other organs take, particularly the adipose tissue and the ductal tissue, they'll take an androgen and they make it estrone, E1, O-N-E, estrone. That's a much weaker estrogen, but is made in large quantities by all these cells across the body. And then within the breast itself, in the ducts in the breast, high concentrations of testosterone actually get converted into estrogen there also, which may tell you why it is you can't measure a woman's blood levels for her estrogens and say, okay, you're at higher risk than you are for getting breast cancer because you've got more estrogen than you do, because it's all local production, right? Systemic levels don't really affect the breast as much as the local production of the estrogen. Now, of all those organs that we're talking about, which one do you think can make a lot of E1?
A lot of what?
Estrone. Now, the ovary doesn't make any, right? Adrenal gland doesn't make very much. Where's the variable?
Adipose.
Adipose. Women who have lots of adipose tissue are factories for making estrogen. And this is what the link is then between endometrial cancer and adiposity. Because women are getting high levels of this weak estrogen for long periods of time when they're not seeing any of the offsetting that we'll talk about, offsetting effects of progesterone. So that's why we see some of these links together, and if you kind of understand where it's coming from, right, then we'll come back to it. All right, so the reproductive system impacts of the estrogen. So what is the endometrium? It's the inner lining of the uterus. So if we think about the uterus, okay, we're thinking here the corpus of the uterus, above the cervix. Right now I want to do something with you. If I tell you that a woman had a total abdominal hysterectomy, she comes into, I had a total hysterectomy. What did she have removed?
Ovaries. Uterus.
Which parts of the uterus? Why is it total hysterectomy? What?
The body, the whole thing.
The bottom is called what?
The whole thing.
The cervix.
The cervix and the corpus. And that's all she had done. Women think a total hysterectomy is when we take out their ovaries, their tubes, and the uterus. They don't think of the uterus as being total. But you know what the name of that surgery is? When we take out the uterus. So it'd be a total hysterectomy, right? Taking out both ovaries is bilateral. I'm sorry, bilateral means both. Salpingo oophorectomy, BSO, right? But we're now talking what's inside the corpus, not inside necessarily, it shouldn't be inside the cervix. We have this lining called the endometrium. And what does estrogen do to it? Well, you don't know this yet, but estrogen has a first peak early in the cycle. And we start the cycle, menstrual cycle, with the first day of bleeding. Okay, so her cycle from the endometrial standpoint is when she starts shedding everything. So she started shedding, and now she has this denuded area that just sloughed off, didn't she? Now this is, what's the purpose of cycling? Why did we shed that other stuff? Weren't we happy with it? Was it getting old?
Oh, because it didn't implant.
What was that?
Because you didn't implant.
That's right, the purpose of cycling is what? Pregnancy. I failed last month. Let's get rid of this. Do the housekeeping. Get set up for next month, okay? Maybe we'll be lucky next month and we'll get pregnant, okay? You just think about this, is the endometrium is a pregnancy-seeking organ, okay? So what it needs to do is it gets rid of last month's failures, and now it has all this denuded area, and it needs to have cells covering it, right? We got to get ready for the next cycle. So what estrogen does is it takes the endometrial cells that were left behind, right, and the basalis leather, and it causes them to proliferate. And what does proliferate mean? It just means divide. So they divide, and cover up the whole area. Are you with me on this? Okay, so that's the whole purpose early on of estrogen. It induces endometrial cell division. We call that proliferation. Guess what part of the cycle this is when we're talking about the endometrium? It's the proliferative phase. Pretty cool? Okay, so now let's think about this, and I know you don't know it yet. But after ovulation, progestin says, no more cell division. We gotta get ready for the baby. We have to plump up the cells, stuff them with snacks for the kid, get a whole bunch of big old blood vessels there where the trophoblast can erode into and sink down, anchor and get nutrition. Are you with me on all of this?
Yeah.
Okay, but it's really important. We gotta stop all this proliferation, all right? So what happens if she doesn't ovulate? Say a woman has PCOS or she has some other reason where she doesn't ovulate, but she has plenty of estrogen, and the estrogen is telling the uterus to do what? Proliferate. So what do we do? Continuous proliferation. And what can that lead to, mischief?
Yeah.
Yes. You can have hyperplasia, can't you? Too many cells. And with all of that, you can then get proliferation that has atypia in it. Some of the nuclei are normal. And then you can get a cancer. So unopposed estrogen, just laying it down for you right now, unopposed estrogen is a risk factor, and a pretty strong one, for getting endometrial cancer, which is the most common gynecologic cancer. Okay, so hyperplasia, and finally to carcinoma. So progestin and estrogen work together in the normal cycle, to get ready for pregnancy. Now, interestingly, in the first half, estrogen comes down, causes the proliferation, then we get ovulation, and progestin comes in and tells estrogen, no more cell division. Okay, so estrogen kind of keeps quiet for a while, but comes time for implantation, we need estrogen again to quiet down the progestin. We'll maybe get into that or not, and allow for implantation. Okay, it actually goes back out to the cells and says, okay, release the contents. So as the blastocyst implants, it allows for release of nutrients in the area, and it causes a really lush lining for the implantation to happen. So around the time, cycle day 21, 22, estrogen levels again are high, okay, but they're not causing proliferation, they're helping prepare the endometrium for implantation, for successful establishment of a pregnancy. So it's kind of yin and yang. They play together in this beautifully orchestrated chorus of activity we call the menstrual cycle. Okay, what else does estrogen do? Well, most of the cycle. Do you all know what the cervix is and what's sitting in the cervix? Have you all seen a pap smear done? Okay, not yet. Oh, you're in for a thrill. Okay. Okay. There's a mucus plug sitting right there, right in the middle of the cervix, okay, as a wall. Okay, and it's thick and it's tenacious. And the little sperm try to get up there, and forget it. We're not letting you out. Okay? And that's most of the cycle, except around the time of ovulation, when there's this huge surge of estrogen. We'll show you where that comes from. About 100 hours, a couple of days before ovulation. It allows ovulation to happen. So high levels of estrogen come in, and you know what they do to this cervical mucus? Get it out. Now, how many of you know about natural family planning? I hate that expression. But you know the Billings technique?
Yes.
Right? And you always ask women to touch themselves to see what their cervical mucus is, right? And what happens is, under the influence of these high levels of estrogen in the middle of the cycle, huge amounts of water are brought in, acellular water brought in, and it thins the mucus, okay? And it makes the quantity so much bigger that it makes this huge tongue of mucus that goes down into the vagina. And it comes, instead of being cross-linked like this, like the fibers would be if you take a biopsy of it and try to smear it out on a side, forget that, can't get it down flat, because it's really trying to guard against anything coming up above. Remember, it's not just sperm, but gonorrhea, chlamydia, all the organisms that can cause infection in this protected area. But here we have, for about 48 hours, this come hither, it's the red carpet, okay? And what happens instead of the cross-linkings and the nasty old IGA that lines this, you know, the keep out type of stuff, there are these little lines, I mean, they're little channels that are a skosh wider than a sperm. Come hither. And currents change. All month long, the uterus contracts slowly, and it goes from the fundus down to the cervix. At the time of ovulation, guess which way the current changes? Yeah. Are you with me on that? Isn't it cool, all these things that happen? I mean, how many of us, we've all seen that movie where the little sperm are swimming upstream, right? And they're busy talking to each other and they have the concept. Do you remember that movie? What was it called? What was it?
Look who's talking.
Look who's talking. Okay, it wasn't the sperm. They can't talk. Okay, and neither can the conceptus, but it was a cute movie. Anyway, the point is, how big is the sperm? Really small. In its whole life, if it really, really tried hard, it could swim maybe a centimeter. Okay, so it can't be doing all of the motion. Okay, it's tagging on to these currents. And these currents are very important to understand. Most people don't know that, we just think of them swimming, but how small are they? Right, and I know it takes days for them to make the journey, okay? And sometimes they get lost because they don't ask for direction. And it's a very inefficient process. How many million sperm in every ejaculate, right? Okay, but there are all these things that go against it. When we get to family planning, we're actually going to take pity on the sperm, and we're going to think of all the challenges that little guy has to, I'm assuming it's a guy, has to overcome to get close to an egg, and then how the two of them have to fight the odds to make a pregnancy. But right now, if you just have a glimpse of what's going on. So estrogen has all of these effects. Now, ironically, during the time of ovulation, which way did the contractions go? Under estrogen, it come hither. At time of labor, estrogen in high levels actually makes the uterus, all the little connections it needs to make, the little gap junctions are all closed together and linked together. The fibers are linked together so she can have a coordinated contraction that starts at the top and goes to the bottom. Wouldn't help if we push the baby in, right? So it has to push it out again. So I'm sure the physiologists understand the little triggers that make all this happen. But I just think that this is such a robust, even within the uterus itself, thinking about the lining of the uterus and then the muscles of the uterus, and then the impact that it has in really facilitating pregnancy and productivity. Okay, so that's estrogen from there on. What else does estrogen do? Well, it increases the rugations in the vagina. What's a rugation?
Folding.
It's a little folding, isn't it? If you think of the vagina, and I love to have my patients think about this, it's almost like you had a gathering in a skirt. Did anybody ever sew? Or maybe a pleating?
Yeah.
That, right? If you stretch that out, you have a lot more surface area. So when that 8-pound baby comes out, right, it can accommodate it. The surface area is so much bigger. And it's the estrogen that causes those infoldings that happen. With menopause, what happens? She loses the rugation, she loses the thickness, right? The cells plump up, you get several more cell layers. That's part of the rugation process, isn't it? And estrogen encourages the growth of lymphatics and blood vessels into the vagina. So you don't have this dried out, single layered, inelastic, atrophic vagina. You have something that can have a lot of transudate, so that at the time of sexual arousal, she has even more lubrication. As we'll learn, vaginal lubrication is almost the same thing for women that erection is for men. So that helps us understand a little bit about why women might be more receptive. I hate that expression. We'll talk about that when we get to sexuality, to sexual overtures. At the time of ovulation, because they have all this lubrication there anyway. And if they're in touch with their own body, they'll respond to that. So it increases the vaginal secretions, and as we said, we'll see atrophy and complaints of dryness. Is it only in menopause that women can have dryness? How about breastfeeding women? right? They shut down their estrogen production, and they can have very dry vaginas. Now you add Depo-Provera, and you're talking Sahara Desert. Remember that. Always give lubricant to patients. All right. What else does estrogen do? Have you had you haven't had microbiology yet of the vagina?
No.
The vagina is an amazingly filthy place. Seriously. I mean, it has anaerobes and aerobes. It has pseudomonas. It has things that normally, if you found it in a wound, would be lethal. It has. And the only thing that's dirtier. Okay. Human bites are so much worse than dog bites, yes, because you've got the anaerobes that are going in there. So the vagina has to be protected. And why is it women don't get lethal infections in their vaginas usually, right? That's really a very healthy place. We do get yeast infections, we can understand some of those, and we get an imbalance where we get an overgrowth of the anaerobes, right? And we lose the protective organisms. And the organism that helps protect the vagina the most is lactobacillus. And what's so great about lactobacillus is that it makes acid, okay? And it makes hydrogen peroxide. Can you imagine that? So it's like your own little douche. Okay, no. It actually keeps the pH of the vagina very small in the acidic range, and the other pathogens cannot exist in, and neither can sperm exist in this. So estrogen promotes the growth of lactobacillus. When women lose their estrogen, they lose their lactobacillus. And they lose a real strong cornerstone to the defense of the vagina itself. What else does it? Let's move away from the reproductive system altogether. I didn't do vulva, but can you imagine that the vulva helps grow the subcutaneous tissue, right? So she has that little fat pad that's there and it keeps the moisture going. So it helps sustain the health of the vulva too. Okay, it protects the bone. When women go into menopause early, or we shut down their estrogen, they get osteoporosis.
Mm-hmm.
You've heard about this, yes?
Mm-hmm.
Okay, how does estrogen work? If I tell you it's an anti-resorptive agent, what does that tell you? Any clues? Okay, remember, there are a couple of cells involved in bone health. One are called osteoclasts, C-L-A-S-T-S, is this ringing a bell?
Yeah.
Mm-hmm.
And then there are the osteoblasts. Okay, so what do the osteoclasts do? They break down the bone. Now, why in the world would anybody design a system where you've got a perfectly healthy bone and you break it down? What?
To resist calcium?
No, okay, yes. There are two functions to the bone. One is mineral storage, but the other is to provide support and strength for the bone. But let's say you didn't need any withdrawals. You're taking enough calcium to make it happen. What's the other purpose? You've got a perfectly healthy bone structure. Why do you want it destroyed? Is this like you're in the army, dig a hole, fill it up, dig a hole, fill it up?
To make space,
What is it?
to make like space.
I can't quite hear you.
I don't know.
To make space, he said?
Yes, that's a very good thing. I mean, you have a little baby like this, his bones have to grow. Okay, but that's excellent. So for growth of the bone, you have to totally remodel it constantly. But at my age,
Oh, is it for like pregnancy to make the bones like more flexible?
no, that's actually a relaxant. We make the ligaments. Okay, I love the way you guys are thinking. But take me. Why do I need any remodeling?
Muscle, like
Bone
Mass.
is very living structure. We all think of a skeleton as that little thing sitting in the, professor's or Halloween just sitting there. But bone will die and break if it's not remodeled. It has to be recycled and rebuilt. And one of the things we find is that when there's little micro trauma, why is it that people who are athletes may have stronger bone, right? Is that they have, like, take your tennis player. He hits, and every time there's an impact, don't you think there's a micro, baby tiny fracture somewhere in that network? Okay, and that activates the osteoclasts to go in there, and like little scrubbing bubbles come in and build a little hole, a defect there. And then they stop working, and then the osteoblasts come in and put down new bone. And during the reproductive years, there's a wonderful balance between the osteoclast activity and the osteoblasts. So any bone that gets destroyed will be rebuilt, okay? Unless you have some sort of metabolic problem or nutritional, you can think of all the exceptions. But the balance is beautiful. And what does estrogen do? It keeps in check the osteoclasts. It keeps them from dissolving too much bone. So when you lose your estrogen at menopause, can you see why bone health would start to be a problem? Because you're actually resorbing your bone at a rate that's faster than the little repairs guys can come in. And so you wind up getting thinner and thinner and thinner bone. So estrogen belongs to a class of drugs we call anti-resorptive agents, and maybe you've heard of Fosfomax. Yes, and some of those other medications we've used to treat osteoporosis, or if she's got severe osteopenia, to keep her from weakening her bone more, in hopes that we will prevent fracture. That's the whole idea. But estrogen is nature's little way of providing that nice balance during the reproductive years. And as you said, of course, it's also the bank, if you will, where we put all the calcium and other things that we may need episodically. Pregnancy is a big reason for that. Okay, so that was the first line. Whew. How are we doing, guys? All right?
Yeah.
So if you have some of these pictures, you can see how estrogen fits into so many different roles. In puberty, you can't get breasts if you don't have estrogen. In fact, if we get a young girl who hasn't had her period, say she should have a long time ago, she's 16 years old and mom brings her in, we ask ourselves two things. Does she have breasts? Does she have a uterus? And if she doesn't have breasts, that says she hasn't had estrogen, right? And then we can work down that set of pathways. So it's very important, at least for breast formation. It binds, estrogen binds to the estrogen receptor on breast cancers and fibroid cells that have estrogen receptors on them. And whereas estrogen doesn't cause cancer, breast cancer, it can stimulate the growth or the division activity of cancer cells in the breasts that have ER positivity. And isn't that wonderful? If we know that she has ER positive breast cancer, now we can target therapy to make sure that that receptor doesn't ever see estrogen. And that's what that whole role for anti-estrogens would be. Take away the ability for her body to make, or for the breast cells to hear the estrogen that she has. So we can either shut down all estrogen production, or we can block it, block her estrogen receptor on her cancer cell with a phony estrogen that doesn't trigger cell growth but keeps real estrogen from binding. And that's what things like the SERMs do, selective estrogen modulating. So that would be receptor modulators. That would be tamoxifen, raloxifene, you've heard about those. And guess what? We also use those agents for osteoporosis, don't we? Okay. Causes melanocyte production. What is melanocytes? Those are the skin pigments. And particularly in pregnancy, when we have high levels of estrogen, yeah, women get the mask of pregnancy, yes. And do we get darkening of other tissue? Yeah, the realer tissue, the linea nigra that runs from the umbilicus down to the mons, all of those take on a darker hue. And that's under the influence of estrogen. And this is more pronounced in women who have darker complexions. The more melanocytes you have, the more likely they are to be stimulated. And remember, this may not go away, right? We don't want to, particularly with birth control pills, we want to respect the cosmetic aspects of this too. And weight distribution, okay? We know that when women have estrogen in high levels, like let's say at the end of pregnancy, the little fat cells in areas where we have high concentrations of estrogen all plump up. Okay, this isn't like we're making more fat cells, but we're chock-ing them full of nutrients, okay, and they're hypertrophy, that's the word you know, growing bigger rather than proliferating. And that happens in the hips, the thighs, and the breasts. And guess why we're socking away all that energy? Breastfeed the baby. Gives us energy to do that. Pretty cool? Okay. Now women will sometimes have a change in the distribution of their weight. when they're on estrogen-containing methods of birth control. And they're not actually gaining weight. You have really good evidence that they haven't put on any. Sometimes they even lose weight, but they'll tell you, no, I know I'm gaining. Why is that? Because their little G's just don't fit the same, right? Their little thighs have gotten bigger, okay? Nobody ever complains about how, well, maybe some people, Dolly Parton might, but most teenagers won't complain about getting bigger breasts. But you put another millimeter onto their thighs. Spider angioma? What are those? Yeah, they're like little capillaries coming out, right? So blood goes in there and it spreads into these little things, and they're just so much fun to play with. You sit there and blanch, Phil. Obviously, we spent a lot of time working on that. Okay, estrogen influence, very common in pregnancy. Okay, so can you see the wide range of impacts estrogen has? Well, let's move to the liver, because this is really the center of activity. And this is where we get worried about estrogen, particularly when we're giving exogenous estrogen. We're giving an outside attack. And what it does is it actually increases the clotting factors through the extrinsic clotting factors, so that'd be 10 and 7. Are you with me on that? Mm-hmm. So that increases the clotting factors. It also decreases some of the factors that are produced by the liver that break up clots. So fibrinolytic factors go down. So we have clotting factor increases, and then things that take down. And the classic agent there is antithrombin 3. Now the net effect is that we increase the risk of blood clots. Usually the normal patient can certainly accommodate this with no problem whatsoever. But if you're listing things that could, serious problems that could be caused by estrogen, thrombosis is probably the biggest one that you think about. Okay, and what do I mean by thrombosis? Well, it could be DVTs, it could be blood clots in her legs, it could be pelvic thrombosis, sometimes you get blood clots there, or maybe one of those clots breaks off and you get a pulmonary embolism. That's not a good thing to have, right? And we can even have stroke, hemorrhagic stroke, as a result of these. So definitely think about this. And it is incredibly odd. Not quite to the point that you'll get a paper out of it, but very, very rare. There might be a blood clot in a coronary artery, so she might get an MI. So arterial thrombosis conceptually can happen. And so you can imagine that when we're talking about giving estrogen to people, the filter we put in, for whether you can have it or not, all has to do, a great deal of it has to do with blood clots, doesn't it? So we think about people who've had blood clots in the past, or they carry mutations, known mutations, or she has other risk factors. She's over 35 and she smokes, or she's over 35 and she has high blood pressure. We know that those other factors predispose, or she's just had a baby, right? That's a super hypercoagulable state. Women can certainly have progestin, but we don't let them in the same room with estrogen until that normalizes. Okay, so that's in the liver. What else does it do? So you got the blood clot picture there? Okay. What else does it do in the liver? Well, you all know that many drugs are metabolized in the liver to be cleared. Right? And then there are certain enzyme systems that are specifically utilized by certain types of drugs to be cleared. Well, estrogen will activate those enzyme systems to metabolize drugs. And particularly the one that we know is the cytochrome B. And it has several other names, but that's the family of enzymes that get activated when you get estrogen. Now, what drugs are we talking about here? Anti-epileptic drugs. So she has seizure disorder, and she's just reached a nice little therapeutic level, and you give her something with estrogen, you might want to double check her levels to make sure that she still is in the therapeutic range. Okay? So we understand that. Now, very interesting, other drugs can affect the metabolism of estrogen, so sometimes it's a two-way street that we have to worry about. So estrogen has impacts on blood clots and on drug metabolism. Most of the time, it increases the clearance and wind up subtherapeutic. There are a few drugs that it actually has a negative impact and you wind up with excess of drugs. and you'll learn those. All right? Now, what else does it do? Well, this is a good story. And this is what got us so excited about using estrogen in postmenopausal women, is that estrogen has a very, very favorable impact on lipids. It increases HDL cholesterol, significantly decreases LDL, and even though it increases triglycerides, and sometimes fairly substantially, these triglyceride remnants that estrogen is associated with are not atherogenic. So on labs, it'll look like her triglycerides went up, but it's not a clinically significant change. Now, there are some women who have very high triglyceride levels, and if you bump them a little bit more, they'll get pancreatitis. Okay, for that reason, we don't give it to high risk. For that, we don't want to cause that, but it's not going to be causing a heart attack. So we thought that the lipids were definitely improved, and that this might explain why early on we saw that women who had taken hormone therapy earlier in life or were on it had a lower risk of getting heart attacks. And that observation in several studies that looked at the issue said hormone therapy postmenopausal reduces the risk of heart attacks. And that was the prompt behind the Women's Health Initiative, which actually purported to have found exactly the opposite. So we'll come to that tonight, I promise. All right, what else does it do? Oh, this is important. Do you know what binding globulins are? Protein
Yes.
binding, serum binding globulins. So you know that you can have a hormone level, you measure total levels of thyroxine, and it looks like maybe they're elevated, but a lot of them are bound, and what you really want is the free, unbound, biologically active fraction. That's all making sense to you? Okay. Okay. So what else does estrogen do is it makes more of those binding globulins. So you have to make sure that your test that you're using for your hormones isn't being adversely affected. Like you don't measure total thyroxine, you measure the free component. Total will go up, the free will stay the same. Does that make sense to you? Therapeutically, we use this. It's really kind of cool. There's one binding globulin that is very important to many of the things we talk about that. Have you heard about sex hormone binding globulin? That's the binding globulin, again, from the liver that goes into the circulation and sucks up hormones. Okay, and what are the hormones? What's the most common hormone we have? Androgens, right? So imagine a poor girl who has hirsutism or she has acne. She's getting overstimulated by the androgen, isn't she? And if we could give her something that would make more sex hormone binding globulin, it would reduce the amount of unbound, biologically active androgen she had. And it would not cure this acne, but it would keep her from making acne in the future. And that's how birth control pills help us with acne. Okay, and they're part of the treatment for excess hair growth too, is that it works indirectly through the liver, making the liver make more binding globulins. All right? So on the dark side, what else could it do? It could increase the production of angiotensinogen 2 and renin, and maybe that could lead to an increase in vasoconstriction and blood pressure. In general, the women taking birth control pills might have a 2 to 3 point increase in blood pressure. So if her diastolic is 78, maybe it'll go to 81. We don't see big swings with modern pills. But is there a susceptible woman? Yeah. Okay, you probably pick up that out of the history. Okay, what kinds of estrogens do we have? We mentioned those briefly. I'll just summarize them. Estradiol is called E2. Diol, E2, right? That's made by the ovary. Now, every now and again, you'll see that if we're using it in pharmaceutical products, we'll put a little ester onto it. Why do we like esters? Because esters are cleaved off of compounds when they get absorbed orally. So we have a birth control pill, one that has estradiol in it, but it's estradiol valerate. You swallow that pill, what goes into the liver is only estradiol. Okay, and estradiol is much weaker, as we'll see, than the estrogen that we see in other pills. Estrone we talked about is made by the adipose cells in the ducts, right? And androgens coming from the ovary or the adrenal glands are aromatized into E1. Forget the androgens there. Estriol, you'll see that is made by the placenta, and it actually can be a marker of fetal well-being. We don't use it very much today. Conjugated estrogens. Now those are generally a mixture of estrogens that depends upon where we get them from. Does everybody know what Premarin stands for? Pregnant mare's urine. Mare's urine.
Mares, like a horse?
Like a horse. They have horse farms, and they collect the urine from these pregnant mares, and they purify it, and they get these complex estrogens. I don't remember honestly how many there were. There were at least 17 that we could name, and then there are fractions of these others. And each of them has a slightly different impact. But this was a source of estrogen. And what some of the people have done is they pick maybe 4 of those and they synthesize them. So they'll be conjugated estrogens is what you'll find some products, synthetic ones. And those are very commonly used in menopause. To provide estrogen, a whole range of estrogens, so that maybe different target tissues might be more responsive. Okay, obviously many other products just go back to square one and give you estradiol synthesized. Now what do we use in birth control? By and large what we use is ethinyl estradiol, and you'll see that's EE, right? EE is many times more potent than any estrogen made in our bodies. And we cannot use normal estrogens because they don't live long enough. They get conjugated and excreted. And when you swallow a pill, it has to last all day to support the endometrium. So you put an ethinyl group onto an estradiol compound, and it makes it resistant to metabolism. So maybe it'll get through the liver many more times and circulate and help support the endometrium and keep her from having unscheduled spotting of bleeding. There's one other estrogen from the birth control world, and it's called mestranol. This was the one that was in the first pill. And as it turns out, it's a prodrug. The body swallows mestranol, goes to the liver, and it converts it to ethinyl estradiol, and that's what's the active agent. Okay, but it's listed as mestranol, and it's only in the very high dose pills. I just don't want you to get confused, okay? This is nothing new. It's converted into ethinyl estradiol in the liver. But it's important to realize 50 of mestranol equals 35, maybe 40 micrograms of EE. So it's not a 1-to-1. You need to know that. We'll come back to that, I promise. Maybe not here, but when we get to contraception, you'll get that again. All right. So what does progesterone do in the endometrium? Once the endometrial cells have undergone proliferation under the influence of estrogen, progesterone will come in and cause those cells to enlarge and fill with glycogen. So when cells enlarge but don't necessarily divide, that's called hypertrophy. So we have hyperplasia, is excessive amounts of proliferation. So we have proliferation, hyperplasia, and we have hypertrophy of cells. If the progesterone is given without having the cells see estrogen in the beginning, it paradoxically leads to thinning, right? Because it's going to block, it's going to say no more proliferation, right? That's what progesterone does. Okay, so you wind up with really skinny little endometrium. So on the one hand, if estrogen comes first and lays down the cells, progesterone will make those cells grow and you have a thick, lush endometrium for the fetus to implant in. If it comes early in the cycle, she'll never see her own estrogen or enough to cause a thick one. They'll have a thin, almost menopausal. What else did progesterone do to help establish the pregnancy? Well, interestingly enough, fertilization happens in the tube, you know that, right? And the tube is not open enough for the conceptus to come through. And what happens is the little cell sits there and it starts dividing, doing its little thing, and it waits for progesterone to open up the fallopian tube and to have the ciliary action do what? Which way do we want it to go this time? Into the endometrial cavity. So that's all done under progesterone. That helps control the timing, right, of it. If you have a conceptus little blastocysts eroding into the endometrium, right? Wouldn't that be a little irritant? And wouldn't the uterus usually give a good contraction or two to swat it away? Yeah, but progesterone does what? Quiets the endometrium, so it doesn't contract. We use this therapeutically now to try to prevent preterm labor. What else does it do? Well, it raises her body temperature, and that creates more metabolic energy, right? And you know that from natural family planning, remember the basal body temperatures? With progesterone, she sees a rise in her temperature, and it's sustained into the pregnancy. And very importantly, progesterone from the ovary supports the pregnancy until the second trimester when the placenta can take over. So progesterone is very important in all sets. And historically, why was it named progesterone? Because it supported the pregnancy. Now, ironically, if we give it in very high doses, it suppresses ovulation, and it's one of our best methods of birth control. Okay, so what else does it do? Well, do we want any more sperm coming in? Do we want any pathogens coming into the endometrium? After we've had fertilization or we've had ovulation? No. So progesterone thickens that cervical mucus, makes it like the wall of China, nobody in. Okay, until it's time for, we lose the progesterone and she starts sloughing. At high doses, as I said, it slows apoptosis. So in the ovary, if you see progesterone, then you're going to have longer cysts. They can persist for another month or so. All right, what else does it do outside the reproductive system? Oh, you guys are going to love this. It induces vasoconstriction. We need that in pregnancy. We need the vessels to relax to be able to accommodate more vascular plasma volume. We need lots more fluids in the body to carry the nutrients to her and to carry off the weight stuff. And we need capacity for that. But what's the downside of that? Varicosities. And if you add some other things to it, hemorrhoids. Okay? It induces the proliferation of cells that have progesterone receptors. Are there breast cancers that are ER/PR positive? Yeah, same thing there. Same sort of thing. Fluid retention. And a very special thing about progestin that we'll learn about more in pregnancy with human placental lactogen is that it's a competitive inhibitor for insulin. So it keeps the mom with higher levels of glucose for longer. Okay, so yes, please.
I don't know if I missed it. What's PR positive?
I'm sorry, what?
I don't know if I missed it. What's PR positive?
Progesterone receptor positive. Thank you for asking. What else does it do? Oh, you love this one. It slows motility. Now, why would that be important in pregnancy? So the mother would have more time to extract nutrients out of her food. And what does that wind up with? Constipation. She took all the fluid out. Now add that with vasodilatation and a little pressure from the kid on the rectum. Now you got a gorgeous hemorrhoid, okay? And then women can express that as bloating also. And we talk about contractions everywhere. It slows the flow through the gallbladder, so that leaves more time for those little crystals to precipitate out. Okay, and maybe she'll form gallstones at a higher rate. So can you see all the impacts that are there? And I haven't gotten through all the CNS ones, and I promise I won't. Okay, so I think it's time for a break. What do you think? We'll get back to androgens later. What do you usually like? 5 minutes, 10 minutes? What do you need? 5. 5 it is. Go for it. It's very important you understand the impacts that the difference between the estrogen and the androgen impacts on the whole system that we're talking about. What does androgen do? Well, do women who are bodybuilders and are using little supplements on the side have periods? No.
Oh.
And what it does is it thins their endometrium, block the estrogen there. In the ovary, women who have excessive amounts of androgen. Can you hear me in the back, or should I use the mic?
No, we can hear you.
Okay, I'm a mother, you should hear me. But okay. All right, that what it can do is it can delay ovulation or even prevent it, so that high levels of androgen in a follicle, ovarian follicle, if you look at the ratio of androgen to estrogen, if it's too high, that follicle just can't go forward. And that's what we see a lot of when we have women who have PCOS, polycystic ovarian syndrome, that they're, at least locally, their androgens are in a high level. And so that can prevent ovulation. And androgens also resist migration. So you have these little tiny follicles throughout the ovary, and they stay for months and months and months and perpetuate this syndrome, rather than having the decent, it's kind of like relatives who ought to go home. You know what I mean? They hang for another couple of months. You know, that's what these guys do, and they have the systemic issues, or we'll say visitors who go home. Okay. So at the level of the ovary, the imbalance between the estrogen and the androgens can cause problems. You know that it causes sebum production. That's what causes at the base of the hair follicle, right? And it promotes the growth of sexual hair, and that's what women have with hirsutism. So you get pimples, oily skin, sexual hair, all of those types of things. When you have too much androgen, not enough estrogen, or maybe a sensitivity to androgens, okay? But in general, you can see the yin and yang. Well, here it goes. At the level of the liver, androgen can mute the activity of the estrogen. So whereas estrogen should increase HDL, androgen will lower it. Are you with me? So you get an unfavorable lipid profile when you have the androgens. And it will decrease the binding globulins. Have you ever seen those bodybuilder ladies on their androgens in their cute little bras? Do they need them?
No.
Does it increase the muscle mass? Yeah, that's why they're doing it. And at the bone, why is it men's bones are stronger than women's bones? Because the androgens not only control, they have estrogen that controls the osteoclast, but androgens promote the growth and activity of the osteoblasts. So they build more. And at the level of the bone, guess what can happen? It can convert into estrogen, which will also control the osteoclast. So you get more osteoblasts and less osteoclast. So net bone. So in these places, in the breast, in the bone, androgens can be converted into estrogens and have those effects that we talked about. I'm not going to give you all this. Okay, I'm just giving you a list. A friend of mine at Western who gave this lecture to their students had these slides, so I thought I'd give it to you. By and large, what we use these for would be hypogonadal men who need androgens, right, to sustain them. But there have been some androgens that have been formulated for women who are postmenopausal, who don't have their ovaries, to help increase their libido. Okay? And here we have the high efficacy. I just gave you, we have it in patches and gels, implants. I've done a fair amount of work with one of the world centers in andrology and trying to find a hormonal contraception for men. They have these pellets. They're about the size of my thumb. Okay. And I had to place them in the bellies of our guys. It worked, but...
Whoa, hold up, what?
What?
What is that?
Sound interesting.
I didn't.
It was because testosterone, if you give high levels of testosterone, it'll block spermatogenesis.
Oh.
Okay? And one of the big things that we have, why don't we block the brain from sending down the signals that make the sperm happen? Well, unfortunately, when you do just that, it also shuts off testosterone. And the guys are big, they don't like that. Okay?
Does it cause them to, like, you know, I heard, like, there's people who are, like, on testosterone or whatever, does it cause them to, like, be more angry and stuff like that?
Yes, that was part of the issues that we have, much more aggressiveness. And perhaps even more significantly, it's pretty bad for the liver.
Wow. And how often would they be taking that?
Well, no, this was just an experiment. I did it, these pellets lasted for 3 months, and so I did it twice on these guys. We just wanted to show whether this dose would reduce the sperm count down to something. And it's interesting because we had a sister site in China, okay, and those guys are skinny as rails, okay, and you could actually count the little pellets in there. My guys were like Santa Claus, okay? and they didn't. And the guys in China, you put the little pellets in, and zero sperm. I mean, as fast as they could get to azoospermia. My guys were beating them down to get them to 3 million or something like that, which is still low count and subfertile. But but it proved the point that certainly different doses, but that wasn't the way we're gonna go. With guys, we try to give progestin, but give a little androgen add back, because the guys do.
Okay.
But the thing is, with all of these, how do you give testosterone back? Okay, the easiest thing would be a patch. Pills don't work too well, it's bad on the liver. Could you put a little patch on? Well, unfortunately, what does it give you? Oily skin?
No, yeah.
Right, so it doesn't stick. Okay, could you give a little gel? So that's what our part of our issue has been with the simple progestins and add back testosterone. We really don't have a good add back product for the guys. Could we come up with a compound that could work part of the way one way, part way the other? And that's kind of what we've been doing more recent years. Hang tight. We keep promising we're going to have something for you guys.
I'm good.
Okay, for the woman, how do I get rid of this stuff? Does this go away if I do anything?
What's what?
You guys find it distracting?
No, it's fine.
Just over there, okay, I'll go back. So it doesn't bother you. Okay, so let's go back. For women, you get facial hair, that'll be secondary sexual hair, comes in at excess levels. You can have the difference between hirsutism and virilization. Okay, irreversible changes. So her voice deepens, or her clitoris gets big. Are you with me on that? Or maybe she gets the alopecia, the male pattern balding, that's irreversible. So hirsutism, hair growth is excessive, and it is in virilization too, but she has these body changes that she'll never be able to reverse. That makes it virilization. Okay. If you take them in pregnancy, could you make a little baby girl into a little baby boy? Crosses the concern, doesn't it? So she's bathed in all these hormones and may actually convert. Guys can get acne. Now tell me why you get gynecomastia. What happens to women's breasts when you give them testosterone? Why do men develop breasts?
I don't know. Is it because it's converting into estrogen?
Yes, very good.
Hey.
That's the local conversion into estrogen, so you get stimulation. Okay, decrease in spermatogenesis, hair loss, and then just as you said, aggressive behavior and erythropoiesis, so that you might actually get too many red blood cells that are there. And then you get edema and heart failure sometimes. Okay, so let's talk about perimenopause and menopause. Perimenopause is the time when woman starts noticing some signs or symptoms that show that peak reproductive years are past. So if her periods become irregular, right? Or she starts having hot flashes, or maybe her vagina. There's no one test. It just says your follicles are less stimulatable. You're beginning to run out of follicles. And menopause has a very technical definition. It means no menses for 12 months without any other explanation. And what it does reflect is that the stimulatable follicles in her ovaries are done with. Okay. Now, you could put a little note on that because somewhere around age 68, one of them wakes up. Okay, but the ones that are going to be cycling or responsive aren't there yet. So no menses, 12 months, and what can happen is that her symptoms and problems develop because of her low levels of estrogen. I didn't mention perimenopause is characterized by tremendous fluctuations in estrogen levels. That's what causes a lot of the problems. After the menopause, we're talking about things that relate to the loss, absolute loss of the estrogen. Now, is she totally bereft of estrogen? Why not? Does she have any estradiol? What kind of estrogen does she have? Estrone. And where did she get it? So the androgens are still coming for at least 5 years after menopause. Her ovary still makes the androgens, and her adrenal glands are going to make androgens for the rest of her life. And so those get converted into the weaker estrogen, and she still has it. Now, that helps explain why some women suffer more than others, right? Not all of it. We have sensitivities, and we won't go there. So, moving on. Not moving on. So menopause really represents a an estrogen deficiency state. It does not mean, please, big letters, that we are going to replace every woman's estrogen when she hits menopause. Those days of hormone replacement therapy went away more than a decade ago. Get the R out of it. If we're going to give hormones, it's for hormonal therapy. She has a reason we're giving it. She has a symptom we're dealing with or a problem we're dealing with. It's not automatic replacement. It is not forever. Right? It is for an indication, and we will give her the lowest dose she needs for just as long as she needs it. Right? And she needs it until the risks outweigh the benefits. We'll stop it when she doesn't have a problem anymore, or we may have to turn to some other therapy when the risks from using the estrogen come up. Now, what do we talk about? What happens to skin without estrogen?
Thins out.
Talk to me.
It thins out. The skin thins out.
Thins out, absolutely. So have you seen these little old ladies? They go, well, there's one. Right? You lose the subcutaneous fat there. You lose the fluid retention abilities, the gags that are under the skin that hold water into the skin. And the slightest little bump and she'll bruise. Now that sounds frivolous, skin does, but honestly it's our biggest organ and it is a huge importance in terms of maintaining protection for the rest of the body. So if it's thin and not as well perfused, can it be subject to infection or breakdown? Totally. So yes, it thins out. And we see that when it thins out and she loses the water in her skin here, what does she get? Wrinkles. Yes. Okay. Why do women rub estrogen into their skin and pump it up and we can rub it young again? They come in and they want vaginal estrogen. And I go, yeah, I know where you're putting that. It is very important to us. Skeleton, we've already talked about the loss of estrogen, accelerates the loss of bone mineralization, hastens the onset of osteopenia and osteoporosis. Genital urinary. What impact does low estrogen have? What happens to the labia?
Atrophies.
Atrophy. So you have less fat there, right? Could she bruise more? What happens inside the vagina? She lost her lactobacillus. Maybe she's more susceptible to different infections. What happened to the side walls? Dried out, thinned out, right? Try doing a pap smear. You know, it might not be possible to be as comfortable. You want to be able to use lots of lubricant when you do that. What's the other part of the genital urinary system? The urinary, okay? The urethra at the trigone level has more estrogen receptors than found anywhere else in the body. And what does she develop? And she loses support, incontinence. Okay, so certainly that, and now you have moisture that's resting on the vulva that has thin skin. Ugh. Right? Can be very, very difficult there. Cardiovascular impact, yes. Now let me say, particularly for cardiovascular, just because we know that low estrogen increases her risk for heart attack, does not mean that giving her estrogen will prevent that. Are you with me on this? So that estrogen does have wonderfully beneficial impacts on lipids, right? It decreases plaque, so cardiovascular risks do go down. And what happens on the other side of it is that women, when they go into the menopause, increase their risk for cardiovascular disease. There was a wonderful observation in the, probably don't have time, but in the 60s, they suddenly woke up to the fact that guys have their heart attacks 10 years before the women do. Okay? And the difference between a man and a woman, estrogen. So what do? They gave guys estrogen. Okay? And not, do you know the doses we talk about with Premarin when we're giving Premarin to women? Premarin was the estrogen. Well, today it's 0.3. In those days it was 0.625. How much Premarin did we give these guys? 10 milligrams. Okay? And they started having chest pain and falling like flies, but if they fell forward, they were cushioned. As soon as they realized that this was absolutely not going to work with the body, When you stop their estrogen, what do they get? Hot flashes.
Wow.
Bad idea. Okay, but to see how this all fits together, and the CNS, yes, we do know that hot flashes are controlled in the brain and they're perpetuated through the body, and that we actually do make a difference in what we'll talk about when we get to hormones, in the temperature thresholds that women experience, that it shrinks, the little zone that women zip around in, shrinks after they lose estrogen, expands back out so that she can tolerate swings without having hot flashes, changing her blood pressure, changing any of this. So very important changes in the central nervous system that we can see. Nobody in his right mind would start a woman in her 60s on estrogen. Okay, but if you did take a 65-year-old woman and start her on estrogen for the first time, then you may increase her risk of getting dementia. It really was only in women who were over 70 that we saw that in, but we don't do it, so it's more of a gee whiz type of a note there. Okay, I'm just not doing what I need to do. So the target for estrogen, colon cancer went down. When estrogen and progestin went down. Breast cancer, we'll talk about heart rates and motor. Teeth, absolutely, teeth health is improved with estrogen. And there's actually dry eye is reduced with estrogen. But those are estrogen receptors there. But the problems that women develop are in different timelines with the estrogen deficiency. We're talking about hot flashes today, and the hot flashes actually do act for many more years than most women do. But cardiovascular disease doesn't start appearing until the late 60s, right? You can see that. Same thing with the osteoporosis. But the problem has its roots when she first loses her estrogen. Now what happens, I promised to stop this, but you can see that estradiol levels drop shortly after the last period, but testosterone levels produced by the ovary maintain pretty much constant. So that's where we're getting our estrogen from. Okay, so what are some principles? If a woman has menopausal symptoms and she qualifies for estrogen, the estrogens are used alone. We only use estrogen if she has had a hysterectomy. The only organ that we have to add progestin for is the endometrium. No other organ needs to have progestin. Doesn't help with breast cancer, doesn't help anything else, okay? Why is it that we have to use progestin? What is progestin? Progestin is the whole family of progesterone is a kind of progestin. The artificial progestins are progestin. Okay, so why do we have to add a progestin if she still has her uterus? Absolutely. So what was the way we called that? If we're giving her estrogen without progestin, it's called unopposed estrogen. Whether she's doing it to herself by not ovulating, or we're doing it to her by only giving her estrogen. We are creating a situation where we're increasing her chances of getting endometrial cancer. So we add a progestin, yes.
So the reason you're giving,
I'm sorry, I'm having trouble hearing.
no, it's okay. The reason why you give the estrogen and the progestin is because the endometrium needs for proliferation.
Because we know the estrogen will proliferate the uterus, and I need something to keep that proliferation
Thank you.
from going on to atypia, right? Hyperplasia. So whenever you give an estrogen, you give a progestin with it. If she has a uterus. If she doesn't have a uterus, there's no benefit. And certainly not routinely give her progestin. So you got that concept? What comes around, that's cool. Okay. Okay, so the amounts of hormones that we use in menopause are much lower than we need to use in reproductive age. You don't know it yet, but what we're doing with the hormones in the reproductive age is blocking ovulation. Here, all we're doing is giving her enough estrogen so that she doesn't have hot flashes, right? We're using uterine protection only, not ovulation. Particularly, we give so much. The estrogens we use in menopause are a lot weaker. So it may look like the dose is higher because we'll be giving milligrams instead of micrograms, but the estrogen we use in hormonal birth control is so much more potent that the estrogen in birth control pills is somewhere between 6 and 20 times more potent than we would give a woman in the postmenopausal years when we're giving her estrogen to help her with her problems. Does that make sense? We give physiologic doses in menopause. We give pharmacologic doses to block ovulation and protect against pregnancy. Okay, this is systemic, never mind. All right, so estrogen is really the most effective therapy we have for hot flashes or for anything else. Does that mean every woman with a hot flash should be given estrogen? No, we have many other options that if she's not troubled very much, we can try some of these other simple lifestyle, layering your clothes, carrying around a mist, just all those types of things. Avoiding triggers, hot flash triggers, can make a woman much more comfortable. They have sheets that absorb moisture at night so you don't have to keep the window open and freeze him to death in the middle of winter. But there are all these things that we can do ahead of time that we will cover when we get to the menopause. But if we're focusing on the hormonal therapies and pharmacology, then these are the types of things that you got. So the Women's Health Initiative was convened. It's a huge study. It was supposed to be $750 million. It ran over costs, even though it was stopped early. And what it was to investigate initially was the cardioprotection offered by Hormonal. Every study had shown us that we're going to reduce the risk of heart attacks in women who took hormones. And so what they did was, they did 2 studies. When they took people who had already got cardiovascular disease and saw, well, will we prevent heart attacks if they have this? And the answer was no. And the second study came along and said, healthy menopausal women. Well, I have to put quotes there because, well, you'll appreciate this. In order to get into the study, you couldn't have had a heart attack or a stroke in the last 6 months. For me, that's not healthy, okay? And we had 40% of women had diabetes, high blood pressure was all over the place. That's not healthy, but it was a healthy sample of what's out there in the menopausal world. Most Americans were even sicker in the population that we studied. So there's always a confusion around that. But they looked at those women and tried to see, and since they had other questions, they weren't quite sure, does it increase breast cancer? What does it do for colon cancer? What does it do for endometrial cancer, ovarian cancer, bone? We had studies that showed us in small numbers what estrogen did for bone, and we needed a large study. So they had a global index of things. And this was the Women's Health Initiative. And the results from the estrogen plus progestin arm were a lot different than they were for the estrogen alone arm. They actually stopped the estrogen and progestin alone arm at 5 years because they saw that they thought that global index of benefits versus risks had tipped over to the risks. There was a lot of controversy because the evidence for breast cancer was so very weak. Many of the people said, well, let's do it 1 more year. But they said, ethically, we can't. So they stopped that arm of the study and they published their results. And honestly, it's taken us nearly 15 years to understand those results, that if we look at different groups in the study, we find different results. So for instance, for cardioprotection, don't give a 60-year-old woman estrogen to prevent a heart attack, right? She'll have an increase in her risk. She already has atherosclerotic disease, right? And we know that estrogen initially destabilizes plaque. Later on, the favorable effects that the lipids give you protect against it. But if she's already got plaque, you need a very strong heart. So don't count it as therapy. But what about the younger women? Absolutely no increase in heart attacks. Okay. And with breast cancer, we'll see no increase in breast cancer if it's used for less than 5 years. And even if she has an increased risk, it dissipates and she gets back to her own baseline in a matter of years. So it's not like the rest of her life she's at increased risk for breast cancer. So these were some of the things that has taken us a while. Now in the estrogen alone arm, absolutely no increase in the risk of heart disease, absolutely no increase in the risk of breast cancer. Okay, but nobody knows that. right? Everybody says estrogen, breast cancer, right? Okay. Where am I going? I'm the wrong way. So how do we know that estrogen is the best? Well, placebo-controlled study is what you need, right? Because hot flashes people don't walk around with hot flash meters on them and measure them. It's just they tell us how many. So coming into the study, these women had to have moderate to severe hot flashes, and we're looking at about 40 a week in one group and 60 a week in the other. And they randomized them, the group that got placebo first, and a group that got estrogen first, and then unbeknownst to anybody in this study, they were switched. So it's a double crossover design. Isn't that beautiful? Double blinded, randomized, double crossover. And you can see estrogen really works, right? And even though the women didn't know that they were being stopped on estrogen, right, and given the placebo, boom, up the hot flashes went. So it wasn't the knowledge that it was there. They just didn't. Okay, and here you saw a huge placebo effect, 50% reduction that was maintained, right? But when you gave them the real estrogen, you saw a significant reduction above and beyond the placebo effect. So that's the kind of design you want before you get behind anything, right? You don't want to have a gee whiz, I feel so much better, like the swing on the front door, 2 case reports out. That should bring an interest, but not be something that you'd act on. Okay, so the estrogen products we have, historically conjugated equine estrogens, and they come as oral or vaginal creams. Then the conjugated takes the horse out of it, and they have fewer estrogens, and they do the same thing. And then more recently, people have turned to synthetic estradiol, and patients seem to like that. It was the thing that held us up for a while. It was so much more expensive than the conjugated equine estrogens, but then the equine estrogens went very expensive, and then it didn't make any difference. And here we have patches, estrogen patches, and that seems to be maybe because of first pass in the liver, that maybe the weaker estrogen put through the skin may be associated with a decrease in venous thromboembolism. We did see an increase in blood clots in women who got estrogen in any therapy, with or without progestin. So that is an important issue still. And then other compounds are coming in. And then if you're going to be adding a progestin just for endometrial protection, right? These are the kinds of progestins that we have available, just so that you've seen some names of them. And probably the most common one is MPA. We're going to see that in many different ways. We'll see it when it's given as a depot form, as an injection, as a really wonderful contraceptive. We see MPA used to help control bleeding by itself, and then it balances out the estrogen in hormone therapy for postmenopausal. So here we go, stroke and venous thromboembolism for estrogen-only therapies. The odds ratio of getting it with the oral is higher than we get with the transdermal. Unfortunately, it's the same group that keeps publishing these data. I wish somebody else would do it. They keep rotating the first author by the, who's in the group. Okay, and they go back and they pick up their last one and they add 4 more cases and they have another paper. You just wonder how many are we really talking about. But right now, it's already been embraced. It has biological plausibility, and if the cost isn't that much different, and she's willing to use a transdermal, it may be our first line therapy. How bad was the coronary heart disease? This is estrogen progestin therapy. And when I say relative risk, do you guys know what that is? So she has a point estimate of 1.24. That means if it were the same risk as between the placebo group and the group receiving this treatment, the relative risk would be 1. There's no difference. You take what the risk is for one group and you divide it by the risk in the other group, and if they're the same, the ratio is 1. If the one group is higher than the other, then the ratio will be greater. Does that make sense? Mm-hmm. All right. And so this was 24% increase. But look what it was with estrogen alone. It was actually less. Okay, now what should I say? Believe that this is really an increase or this is really a decrease? That's where this 95% confidence interval. Has anybody talked to you about that? Yes? So the rule is if the confidence interval includes or crosses 1, you cannot say there's any difference. Because at one extreme, it could be exactly the same. Right? Remember, this is a sample, and so you've got to see how big is my sample, what's the relative risk, all this type of stuff. And from this, you do your calculations that 95% of the time, the real number lies somewhere between 1 and 1.54, 50% increase. But look at this, hip fracture, 0.66. Where could the real answer be? Well, it could be a 55% reduction or a 4% reduction, but it's all less than 1, isn't it? So there is protection. What about this one, stroke? It's 1.39. It could be as low as a 10% increase to a 7, but it's all an increase, isn't it? So here you can say it is an increase. Here, right here, invasive breast cancer, looks like it's a reduction by about, but gosh, it could be, you know, a 40% reduction or a 1% increase. So we can't say, darn, we got close, didn't we? To say that estrogen actually reduced, but we can't. Rules of the game. If it crosses or includes 1, we can't say it's any. Do you remember that? Because every time you read an article and they say 20% increase, but the confidence interval is so broad and it includes 1, throw that article away. Okay, you can read it, right, to see what other strengths it has, but don't change your practice. Right, it has to be clear that there is an increase. Then we can talk about whether it's a significant increase. Look at venous thromboembolism. Looks like a 30% increase, doesn't it? But it went from what? Protection all the way to a doubling of the risk. Can you say anything based on this? Good for you. Okay? Seriously, that's the kind of critical thinking we need. Colorectal cancer significantly reduced with estrogen progestin, but not with estrogen alone. And what about death? Didn't you think people were dying right and left if you read these articles? Absolutely not. No increase at all. Okay, very important insights to say. And you need to know this so that you can reassure, because patients think hormones are poison, right? And I think people may be moving away from this, but your colleagues are still going to be very concerned. And this is the absolute risk of cardiac. Remember I told you that women who took hormones early, and this is even estrogen plus progestin, there was no increase in coronary heart disease, right? But if you give it to older ladies, 20 years from menopause, when they got atherosclerotic disease, you're going to increase, you're going to almost triple their risk of getting a heart attack or other coronary disease. What about estrogen alone in breast cancer? Look at this. The 2 most common kinds of breast cancer, there were statistically significant decreases. But because the lobular went up by a little bit, our net wound up at 1.01. And we can't say there's protection. But what can you draw from this? No evidence that it increases the most common. Are you with me on that? All right, these are important lessons to learn. We'll come back to them again. And then we have tissue-selective estrogen complexes that we can use, and Duo-V is one of those, where they took the progestin out and they put in a SERM, but they combined it with an estrogen. Okay, let's talk about the epidemiology. This is normal. And why don't we have solid bone? Why is bone honeycombed? Obviously, it's easier to make withdrawals. You have more surface area. But think about it from, yes.
We'd be
Huge! We'd have to live on the moon.
Yeah.
Okay, what else about the strength of it?
You need some way to produce your cells, the correct cells, because they produce them now.
This actually absorbs shock better. Right, you have force it put here and it's transmitted and spread, whereas you would fracture a solid. Right, it's an all or nothing. This spreads the force along. And it also gives you flexibility. You can twist and turn a bone, whereas if it were solid, it would be like a hammer, right? So this gives us the support that we need to the bone. Now, we obviously have to have solid bone on the outside because that's where the ligaments attach, right? And we have to have the flexibility. But the matrix inside, this is so much better. In fact, it was very interesting that after people began to see the bone and they looked at engineering plans for bridges, they discovered that engineers had found these principles. And if you look at bridges aren't solid, are they? They have the beams and the supports, and they have all of these other structures so that they can take the force of the trucks going over them while the wind is moving sideways and they don't collapse. So that the analogies here, they could have known what was going on in the bone. We could have been smarter from the beginning, but this is normal for T-work. Well, what happens when you get the osteoporosis? Look how tiny these little spicules are. Can you see if she coughs, she's going to break 3 of those, right? She already has huge gaps. See where the remnant is? If I take this bone and I give it all the therapy I can give it, all I ever give this bone, you know, maybe I can make this a little stronger so it won't happen. Really, our whole thought in osteoporosis is to try to prevent, we try to keep this as healthy as it can for as long as we can. Okay, I'm going to move this. Here's the vagina with irrigations. Here it is very thin. This is very generous shape, but look at how thin that epithelium is. And if you give the weakest little estrogen every now and again for 6 weeks, look how thick that is. Can you see the blood vessels are coming back in again? If she's been bereft of estrogen for a long period of time, it may take quite a lot of time to get the blood vessels and lymphatics back. Maybe even a year. She's going to have to use lubricant, but she won't tear when they try to have sex. Okay? So it gives her the elasticity she needs. And we talked about if she has genitourinary syndrome of menopause and we're treating it with estrogen, we want to give her topical. We're not going to give her systemic. Give it locally. So we've seen several different ways of doing things. And I think it's time for another break. Do you want one?
Yeah.
5 minutes? You sure?
Yeah.
Okay. All right, so here's a quickie. This is a brain buster. Are you ready? We're going to do intro to the menstrual cycle. And you know that there's you've already had other hormones, so you know hypothalamus, pituitary, thyroid, yes? And you know that those are all stimulatory, and you know the hypothalamus sends down a message, TRF, to the pituitary that causes the release of TSH, and TSH goes to the thyroid and has the production of T4, T3. Okay, so the same thing. GnRH, though, is a weird one. And we'll get a little bit more understanding of this. It comes out in pulses, and the pulses vary in amplitude and frequency throughout the menstrual cycle. And actually the cube, kind of like the little puppeteer that controls what's actually going on at the ovary. The second thing that controls it is actually the ovary, talking to the pituitary and the hypothalamus. Okay, and you already know this. Why is it that TSH, you're hypothyroid, and you give her thyroxine? What do you measure to see that she's gotten adequate doses? TSH. Why not just mention do T4? What's the TSH telling you?
That it's working?
What?
That it's like working? Like
That there's adequate amounts, right? And what's the principle? How does the hypothalamus and pituitary know that you're giving enough?
Negative feedback.
Negative feedback. It doesn't care where the thyroxine is coming from. It's negative feedback, and we will stop stimulating more. Is that right? And if you overdose, what's going to happen? TSH levels will do what? They'll drop. Right? It'll look like she's hyperthyroid because she is. Negative feedback says too much thyroxine, so they will stop stimulating. They can't stop production, right? They can make you stop swallowing, but they won't do anything to add to the problem. They will stop stimulating. Same picture happens with the ovary. So we have gonadotrophics. We have 2 hormones that come down, and their sequential release is very important to the menstrual cycle. But the pituitary sends follicle-stimulating hormone. Let's just call it FSH for now, right? And when that goes down, and LH, good Lord, somebody can't type in this. Somebody is moi, okay? I did that. Okay, let's not do that either. We'll go next, and then we'll go backwards. Maybe not. There we go. Okay. All right, so the FSH causes the development. LH, a little bit of LH causes the cells to make androgens. The androgens go to the granulosa cell, and under the stimulation of FSH make estrogens. Estrogens go to the uterus and cause what? Proliferation, right? Okay. And then, I will show you this when we get to contraception or to the menstrual cycle, the negative feedback to the uterus. The other thing that the ovaries make, I didn't tell you, but they make inhibin proteins. In the first half of the cycle, inhibin B. In the second half of the cycle, inhibin A. They discovered them in the wrong order. Okay, or would have been A and B instead of B and A, but it's B and A. Okay, so now you can remember it. Okay, so the follicles make both estradiol and inhibin B, and both of those go back up to the hypothalamus pituitary, and they say we have this much. So that will reduce stimulation, right? Kind of in a negative feedback situation. Are you with me on that? Now, what's important about this is I told you it almost sounded like we had malpractice. In menopause, I talked about the doses that we give, very narrow range. I can give you a little dose or a little bit more, but I'm not going to keep going. Okay, and how did I monitor her? Did you hear me getting any blood tests to see what I got? Now, how do you monitor? You walk in, you say, how are you feeling? Is that like the stupidest thing in endocrine? When was the last time you walked up to a diabetic and said, well, how you feeling? Probably like to know something about their glucose levels, right? And the same thing with the thyroxine. You want to see whether TSH is normalized. This I cannot do in FSH. I cannot measure anything to see if she's getting adequate levels. Because the feedback loop is not what? Just estrogen. It's estrogen plus what? Inhibin B. And it's both of those going back. If I measured the FSH and said I need to bring that down to where she was in her reproductive years to know I've got enough hormones for her, I'd be overdosing. Because I'd have to give her enough estrogen alone to drop down the FSH. Whereas in real life, both of them are going back. It would take less FSH to drop her to normal ranges. Are you with me on that? So it's the two-fingered release. And patients always want you to measure, I got normal levels. Okay, and what you want to give her is the minimum amount that she needs to control her symptoms, and you have a range. I never go above this. If this isn't working for you, something else is going on, and I have to think about what I'm going to do. Make sense? Okay. All right. And that all has to do with the way the negative feedback works in this system, the menstrual cycle. So we got the hormones running through it. And the hormones and the proteins provide negative feedback loop to the higher centers to prevent excesses. Excess. In reproduction, what would be an excess? Do you lie awake at night and wonder why it is we don't have litters of puppies? Why people get excited when there's a twin? Why it's almost always artificial that gives us triplets? Did any beagle ever get excited when she had 3 or 4 or 5 pups? We're a little different, aren't we? So it all has to do with the negative feedback and the whole menstrual cycle. There is a time when we say enough is enough, and we kill off all the other follicles, and then we come forward with the one dominant follicle and we take it to ovulation. Okay, but it's a very dynamic, integrated process. It's just fun to think about, actually. All right. So let's talk about hormones and oral contraceptives, shall we? Okay, progestin. Progestin, believe it or not, is the thing that provides the contraceptive action. It thickens the cervical mucus, doesn't it? And how does that help us?
Prevents us.
Sperm can't get in. If the sperm can't get in, there can't be fertilization, right? And at high doses, it suppresses ovulation. That's the strangest thing for something that is a progestation, and it has progesterone, all the names there, but if you do too much of a good thing, it actually suppresses ovulation rather than supporting a pregnancy. It can reduce, remember we said if you don't have estrogen at the beginning, you wind up with a thin endometrium. So a woman who has heavy periods, does she want a thick, lush amount of blood, bloody material that she sheds every month? Thinner is better, right? She might not even have any period at all. It might get so thin. It might be like the atrophy you get in menopause. And what distinguishes different pill brands, is really their impacts on metabolic profiles and their half-lives. Now, do you see the last slide? Estrogen is added for cycle control. It has this much impact. It does help suppress FSH, but its only real purpose is so that women won't have amenorrhea, right? They don't have any periods, or they have unscheduled spotty and bleeding. Particularly at the beginning of the history of the pill, having a period every month was incredibly important to the acceptability of the pill, and we'll get into that when we get to contraception. And today, for many women, they really want to see their period every year, every month. And we'll work on that if we can, but it's not healthy, but it is the way they are. So these are our nomenclatures. CHC is combined hormonal therapy. COC would be a birth control pill. EC, emergency contraception. IUD, you know. Progestin-only pill, you might not know. We call it POPs. And then we have selective serotonin. Okay, never mind. All right. So let's move forward with the very best, most effective, and safest method of birth control. How many of you know Nexplanon? Yeah, okay. It has progestin only. That's what we're talking about right now. And the progestin is the third generation. I'll come to that in a bit. And it is effective for 4 years. It takes 27 seconds to put it in, and there's only one medical contraindication. But you do have to be worried about drug-drug interactions because this works by promising ovulation suppression and thickening the cervical mucus. Okay, and if you have anything that metabolizes it more rapidly, it will lose its efficacy. Right, so we have to watch out. We don't use it with drugs that are going to increase the cytochrome P450 system. And what would be a drug that we'd avoid? Something for seizures, right? So Dilantin, Phenobarb, right? We had a previous type of implant called Norplant, and this implant had a first-year failure rate. Are you ready of this? 0.05% pregnancy rate. Is that like slim and none? But if you gave it with Dilantin and Phenobarb, the pregnancy rate was 17%. So we know we have to have it. I don't have those data with the current ones. Very rapid return to fertility. Okay, and etonogestrel, it's a single dose, and the hormone is mixed in with the plastic. And what controls the rate of release is that the implant actually has a releasing membrane. It's 6/100ths of a millimeter thick. That's how thin it is. The whole unit is only 2 millimeters thick and 4 centimeters long. And that much, and the mixture together gives you the hormone. And as I said, there's only one category 4 condition, which is evidence-based, why you wouldn't give it, and that is if she's had breast cancer in the last 5 years. And we'll go through the categories later. So you slip it beneath the skin in the inner aspect of the upper arm, non-dominant arm. Okay, very low levels of etonogestrel, but enough to guarantee suppression of ovulation in all women for at least 30 months. But it is susceptible. And the big one I want you to know about for all drug-drug interactions that have hormones is this one. We always think of the seizure drugs. We think maybe some of the antiretrovirals. But the most potent drug that we have that just knocks cuts them off at the knee is St. John's wort.
Oh, wow.
3 days of St. John's wort at typical dose will increase metabolism in the liver for 30 days. In England, where they used to give 2 birth control pills now and 2 birth control pills in 12 hours, if they're giving for emergency contraception, if they found that she was on St. John's wort, it was 3 now at 3 days. 50% increase in drug. That's how potent it is. We need to have that kind of stuff. So patients oftentimes don't know that they're doing St. John's wort, or they're doing it because it makes them feel better. It's a pretty good drug for mild depression. It's something she can buy for herself. So I don't fault her for that at all. And it's reasonably safe. We have good studies on it. But it's horrible when it's given with hormones. It can really give you, yes.
Is St. John's wort, like, I'm trying to understand this. As far as like a depot shot goes, is that what Nexplanon is?
No, Nexplanon is an implant.
Yeah.
So you think of a tiny little rod, you slip under the skin.
Okay.
Okay.
So would St. John's wort have the same effect on a depot shot?
No, Depo is, what's the name of the Marvel character?
Thanos?
Just that, no,
Hulk.
right, what's his name?
The Hulk?
The Hulk?
The Hulk?
Any of those. It is so strong, there's only 1 or 2 drugs that affect it at all. Okay, so that's my go-to. When I've got these drugs, you just put your finger on it, Depo-Provera will over everything.
Okay. Okay.
It's almost impervious to everything. There are a couple of chemo drugs that
Wow.
can come to it. But these little guys, it laughs at St. John's wort. But everybody else cringes.
Wow.
If they count on systemic levels. Now what's the exception here? The next one we come to. Hold on.
Okay.
So this works by ovulation suppression. I have to put it into the bloodstream, which means it's going to be cleared by the liver, and I may drop below the level of efficacy if I'm using it with. We were supposed to talk about drug drugs, right? And is there going to be anything nutrient-wise affecting this? No, because it's not going through the stomach, is it? Right? Unless it affects the liver, it's not going to do it. Okay. Progestin-only methods, especially any of them. Nexplanon, you're going to, with any progestin, you're going to change her bleeding patterns. You're going to thin the endometrium, and so she may not have a period. She may have a frequent period. She's likely to have light periods. Only a very small percentage, maybe 7% of women, have heavy or prolonged bleeding when they have progestin-only methods. And we honestly don't understand that. We need to do it. Other things, maybe it migrates. It may be difficult to remove. And just to let you know, we'll get to this, there are networks of clinics to support if you have a difficult removal. Okay, and this is, anybody know the name of this one?
The T.
Have you heard of Mirena?
Yeah.
That's the 20 microgram one, release one. And they also have one that releases 12 a day, and that's Kylena, and then there's Skyla. And then Liletta is like the 21. So this elutes progestin, and what does this progestin do? It's sitting there in the uterus. High concentrations in the uterus, hardly anything in the bloodstream. So I can't count on it to suppress ovulation, can I? Because I'm not doing enough negative feedback to reliably suppress ovulation. I don't have high enough levels. But what does progestin do? I've got the fundus, I've got the corpus of the uterus, and then I've got what? Cervix. And what is it going to do? Thicken the cervical mucus. Really very, very, very thick. We've had studies where the portal sperm can't make it 2 millimeters into this, and they have to go 2.5 centimeters to get into the uterus. So this is local, and do I care what the levels are? Systemically, no. What, can she be on St. John's wort? Yes.
Yeah.
Because it's
I don't
not-
care what
not
the
systemic.
circulating levels. I've got this
Oh.
concentration in her uterus, that's what I was trying to get at.
Okay.
So I can either do the shot,
Yeah.
which is so strong, the liver can't beat it down,
Mhm.
or I can put something in the uterus, and I don't care what's going on in the system.
Okay.
So then she can munch St. John's wort. Okay. Now, obviously, we have a copper IUD that doesn't have anything to do with hormones either.
Yeah.
But as an option, if you were thinking about this. But every other drug, every other hormone, you have to think about St. John's wort and these other things that could seriously compromise efficacy. So here we talked about this. This is the high dose LNGIUS compared to, say, the mini pill even, right? Coming up, and then the contraception. So we have 3 different doses I talked to you about with different, we'll talk about that more. Profound effect on the endometrium, and you get bleeding patterns. This is what you were talking about, microcrystals of a progesterone suspended in an aqueous solution. Now there are 2 different types of these. The ones you and I are going to use every day are the IMs. That's the cheap one. Okay, nothing's cheap. But this gives you, it makes a little ball inside the muscle, and the surface area is what contributes to the circulation, right? So you don't want to sit on it, you don't want to squish it out into a pancake, you want it to be a ball. If you're a pancake, you go through it too fast, and they'll get susceptible to pregnancy before the 3 months are up. Okay, it's a little ball, it's all programmed. And you can put the ball in the muscle, or they have a totally different formulation that you can put into the sub-Q. And why would we want to do sub-Q, put it in the belly or in the front leg? Because then maybe the patient could give it to herself. Wouldn't that make access easier? People do sub-Q all the time. I can teach your diabetics how to do this, and this is less than 1 cc that we use this for. So it's supposed to be a huge step forward. We haven't gone very far with it. But those are what's available. We've got different buffers, and they're given about every 3 months. And it's also approved for the treatment of endometriosis. So strong systemic effect, right? Levels high enough to suppress ovulation so much. Do you know what a Rip Van Winkle is? This was a character, never mind. It puts the ovary to sleep. I mean, it's like, well, Cinderella, what do you got the little, wasn't Cinderella, was it? Okay, we'll just leave it. But just put it, the whole thing goes to sleep, okay? And gets so much down that the ovary may not make enough estrogen to support bone. And that's where the concern about bone health comes in. Fortunately, we know it's totally reversible and she'll get better. But for the time that it's there, it's kind of like pregnancy is on bone. Yes, please.
I have a question. So for some of these medications or any sort of like hormonal therapy, I know that it's been said that like if you get off, you get like your body can go back to what it has to do. Has there been any cases where that was not the case? Like
Yeah.
People actually,
Yep.
like they're not able to.
Yeah, you give DEP until the woman's 65. She probably won't be able to.
But I mean like they've been taking it for years or they've had IUD or whatever for years.
No long term, it's only aging. Okay, in terms of harm. If there's some other thing that happened to her, like she got an infection with the IUD, it's the infection, it wasn't the IUD. Because people, the IUD doesn't always protect against STDs. And if you got PID from an STD, not the IUD, right, she may not be able to be fertile afterwards.
So is that saying that if somebody was to get some sort of, because I've heard
Yeah.
that like if you've been taking any sort of like hormone treatments, like there's the chance of like cancer or something.
Yes, it protects against cancer. Isn't that fascinating? This, I would love to take a survey. There are so many things that are totally wrong that women believe. Women don't start on the pill because they're afraid it'll affect their fertility, right? But I want to have babies someday. Well, that's when you stop taking it. But they're afraid that it will ruin their fertility. There are women who are afraid of the amenorrhea that comes with Depo-Provera because they think it means they've gone through menopause, right? And it really hurts that this misinformation is out there because it keeps people from making choices that they would otherwise make. The concerns around cancer, absolutely, everybody believes that. Seriously, I'm sorry, I hope I'm not faulting you. I really appreciate your saying these things because this is what your patients think, okay? And they may not be open enough to challenge you with it. They'll say, no, I just don't want a pill. And you can't find out why, because you could correct it if they, you found out what it was that they knew about, what they thought was true, right? There are women who think the more they bleed, the more fertile they are. And I'll have patients who bleed 10, 12 days a month, get hemoglobins that are dangerously low. What's the lowest hemoglobin you see? I know you've shadowed bunches of people. What's the lowest hemoglobin outside of trauma?
Like a regular 9.
What was that?
I've seen 9.
You see a 9?
Yeah.
I said
7. 5?
6.5.
6.5, okay. Well, I did a study of women at Harbor whose hemoglobin was less than 5 due to heavy periods. Okay, the lowest I had was 1.8.
What?
You said 1.8.
1.8.
Walking.
Okay, and these women were coming in because they were feeling a little tired. Okay,
Yeah, man.
so, I mean, because if you lose it slowly.
Yeah.
Okay, and so these things where they were rather indifferent to it. So I'll just come in and get transfused if I need to, that kind of stuff. And it's just like, this is dangerous to your health, right? Why don't you let us do something to control this? But behind a lot of that is the myth that they feel super feminine if they bleed more, or that this is normal for their bodies. And I think we need to, I know we're running out of time, but in you're doing with medicine and you're dealing with misinformation, one of the main things that you can do is separate natural from health. We get a lot of pushback in medicine today against vaccines, a lot of it in reproductive medicine, well, that's just not natural, right? And then we just remind people that pneumonia and cancer are natural. And in medicine, we're really there to promote health. So we will never win the natural argument, right? And I don't confront it head on, but in my white coat, I'm here to make you healthy. Okay, and you're not as healthy as you could be. This is not healthy for you. It may be natural, but it's not healthy. And I think then you don't get into a lot of the bickering. You just have a different perspective and help them understand what it is that you're on. Is it their choice maybe not to do what you're suggesting? Totally. But hopefully you've given them information so they can make an informed choice. And I think this is uncovering what people hear about. I think that that's very true because these are very pervasive thoughts. And unless we talk about them, then we'll never know what it is we need to discuss with patients. Anyway, so there you go. Next to the bottom, what did you ask? Drug-drug interactions? It's Superman up there.
Yeah.
Okay. Who's the other? We had 3 parts. So Tony, somebody, he played a.
Oh, Tony Stark?
Yeah.
Iron Man.
Iron Man.
Yeah.
I said Superman, I couldn't even get to Iron Man. Okay. But this is the super strong drug-drug interactions, impervious to that. And when we get to contraception, I'll tell you many of the non-contraceptive benefits that we get. But how do injectable progestins work? Inhibit ovulation at the hypothalamic level, thickens the cervical mucus, slows tubal motility, just about anything you want to do along the way, this guy does for you. Okay?
Are HIV risks increased because the people feel like they can't get pregnant? Okay.
Yep. You thin the vaginal wall and the transmission of HIV and maybe higher.
Okay.
One way or the other.
Wow.
Okay, with the thinning of the other. Not as bad as we get with the spermicides. But we'll cover that. That is the underbelly. And that's one of the reasons you might want to have an estrogen there, because what would estrogen do? Why don't we worry about that with pills?
I didn't hear what you said.
Why would we add estrogen? Why aren't we worried about HIV transmission with combination pills? What does estrogen do to the vagina? Thickens it.
Oh, okay.
Right, so
Yeah.
that transmission, the erosions,
Mhm.
that would be decreased. Okay, okay. This is the impact on glucose tolerance, and this drug does have the most impact on glucose. But having said that, it's one of the most popular ones for women with diabetes. It doesn't make you diabetic, but you do have to worry more about potential. Everybody's afraid of weight gain.
That's you.
And I just want to show you the data. I will tell you, every patient you offer Depo to knows that it's going to make her gain weight, and some women will. But in general, double-blinded, placebo-controlled studies don't show any difference. But there are some studies that may have revealed some higher risk with it. So if she puts on weight with the first injection, don't give her anymore, right? She's going to have trouble, and I don't want to put it at risk. When we talk about, we'll talk about that. Mini pill is the go-to. If you don't do anything else in contraception, and you have a patient who needs something tonight, right, you need to start her on something because you're going to be giving her a drug that you don't want her to, well, you're sending her over to somebody else to get an IUD or something like that. The progesterone pill is just amazingly universal. There's only one contraindication to it. It's easy to counsel about because you take a pill every day. There are no placebos. It will change your bleeding pattern. And it's the lowest dose birth control pill that we have. When you add estrogen to this progestin, you have to add more progestin to offset the effect on the cervical mucus. So anyway, just as a thought, this is a go-to, right? And you can start it today, and she uses a backup. You only need it for 3 days, but every other backup is 7. So if you just want to rule 7 days, it's good. So only one category 4 condition. It is more susceptible to drug-drug interactions, though. And you have to be sure that you take it pretty religiously within 3 hours. Okay. I'm going to tell you a story about the different progestins that we have in the pills. Can I do that? And then you can understand the differences in the pills. And I'll give you some references. When we get to family planning, we'll do this. I just don't have time to cover this when we do the 1 hour talk in contraception, so I want you to have sort of a ballpark. So the first generation of progestins were norethindrome based. Okay, and the first pill when it came out, anybody know? It was called Innovin 10 because they thought they had 10 milligrams of progestin. Turns out they only had 9.85 and they had 150 of estrogen. So when you think of what do we have today in pills, maybe a 20s of estrogen, right? 1 milligram of progestin instead of 150 and 9.85. Can you see totally different doses? Well, even with those high doses of pills, and so they didn't have problems with norethindrome. Nice, solid progestin, works well, pretty metabolically neutral, so it's a good pill. I mean, a good progestin, and you find it in all kinds of pills today. Some of the oldest pills that we have, the Orthonovum 135s, the Brevicons, the Modicons, all of those been away. And the more recent ones, like low estrogen, is actually a norethindrome compound. So all of those, it's been around 60 years. Okay, so why do we have any of the others? And the answer is that it has a short half-life. It's only 8 hours. Did it make a difference, one bit of a difference, when they first brought it out? Because how much of a dose did you have? If you missed 2 or 3 pills, you still wouldn't bleed, right? Because you were so high in the dosing. It took, on average, 5 days for a woman from the last pill she took to the day that she started bleeding. Today, it's a day and a half with the doses we have. So the dosing covered up the short half-life. But as we started to reduce the doses of the progestin and the estrogen, we matched the estrogen to the progestin on the way down. What was the problem women would notice? What do you think a short half-life would give you? Say I'm a little late taking tomorrow's pill. Yes, only we don't call it breakthrough. Nothing's broken. We call it unscheduled today, if you can help me with that. But everybody calls it breakthrough, okay? But she would have unscheduled bleeding. And do you think women liked unscheduled bleeding? Nah, of course not, okay? So what did they realize? Short half-life, we got to overcome that. So let me back up just one step. I say norethindrome. How come there's not progesterone up there? Why didn't we use natural progesterone? High doses will block ovulation, won't they? Right? So why didn't we use a natural compound? We had it. Okay, the answer is it's not well absorbed orally. And you know that because in the postmenopausal, when you just needed a little dab of progestin, it had to be micronized before it would go in orally. Okay. So it's poorly absorbed, and guess what? It has a very short half-life. So you'd have to do BID dosing twice a day. Women have enough trouble taking a pill every day. People have trouble taking it, right? Ask her to do twice a day. And at the doses you need to suppress ovulation is highly sedating. So you'd have to wake her up to take her next pill. So it just didn't work. Are we forgiven for that? Okay, same thing with using natural estrogen. It's not strong enough to last all day. So they had to come up with a synthetic. And where did they get the synthetic? They went to a C19 chicken wire. Okay, basically they started with an androgen. Are you with me on that? And they tinkered with it to make it act like a progestin. And that's where they got norethindrome. Okay, so they went back to the same chicken wire and they said this time we need it to be more potent and more long-acting, more forgiving of forgetfulness. So we didn't have the unscheduled spotting and bleeding, right? And we could get around with a lower dose if we needed to. And that's where the second generation of progestins came out. Norgestrel, which is a mixture of right and left-handed compounds, and the one that's only biologically active, which is the left-handed, levonorgestrel. Are you with me on that? Very potent. Little dab will do you. In these pills, the progestin is 0.15 milligrams. Are you with? When you get the levonorgestrel. So you just need a little bit, and it lasts for a long time. Can you see the half-life on that? So if you miss a pill, you're not going to bleed. Okay. Now this was the progestin that's so potent and so long-acting That's the progestin they put in Mirena. 5-7 years worth of hormone in one little sleeve around an IUD. Isn't that amazing? Okay, and that was the progestin we had in the old implants. So it was a very important step forward. And this is a pill that matched everybody's dream. People stopped having breakthrough bleeding. And in fact, I learned in medical school, they said, if you want to learn about a culture or a group, look at the ads in the magazines they read. Okay, today it would be online, but it was really fascinating. What was the ad for this? Well, it was a doctor's office desk. And you know it was a doctor's office desk, and it had a phone over there. It had a patient chart, one, not a stat, okay? And it had a stethoscope. And what was the message here? It had a big red X over the phone. No more callbacks. Red meaning what? The bleeding. So no more callbacks for, isn't that just so cute? Anyway, so that was won the day. So you would think this met what we need. Low dose, long acting, potent. Wow. What was it, soft underbelly? Got a little too much of the scaffolding in it. It was a little too androgenic. And some women complained of pimples and hair growth and oily skin. Right? So the androgenicity there was important. Not every woman did, certainly, but it was enough that people said, okay, let's go back to the scaffolding. And they came up with a third generation of progestins that continued the potency, continued the long acting, but was less androgenic. And that was the third generation with norgestimate, desogestrel, and you know the compound etonogestrel? What is etonogestrel? What is in it? Where did we meet that one? We met that in the implant. And we're gonna meet it in the ring. And we've had it in birth control pills for 20 years. All right? So it's kinder, gentler, and norgestimate, I know you know this one. This was the first pill that offered a non-contraceptive benefit on label. It was for the treatment of mild to moderate cystic acne. What was the name of the pill? Has anybody heard of orthotricycline? Okay, that was the acne pill, they called it. Okay, so because it had less androgenicity and it actually helped clear women's complexions. Because it didn't have androgenicity and it had, what was the thing that really cured the acne? It was the estrogen, wasn't it? Remember, sex hormone binding globulin would soak up the androgens and your own androgens. Because she was suppressing ovulation, her ovaries weren't making as much testosterone, and the sex hormone binding globulin would be soaking up those that she had, and the progestin in the pill wasn't adding fuel to the fire. Okay, so it didn't have much androgens. So you got 1, 2, 3 so far, and that's what all the scaffolding was about. And it's all varying influences of androgenicity and half-life. You can see the impacts that were there. Pretty clear? Okay, so what did the fourth generation do? Gosh knows, I have no idea. Seriously, they abandoned the scaffolding and some idiot said, well, you know what? We have this antihypertensive over here called spironolactone. You guys use spironolactone? Potassium sparing, right? Mm-hmm. Antihypertensive unit. Maybe if we tweaked its compound, here it's got a parent compound. If we played with that, could we make that act like a progestin? And they did. So here we have a progestin that blocks ovulation, has anti-mineralocorticoid activity, so it's a little diuretic, and it's an anti-androgen. We use spironolactone to treat people who have hirsutism. It blocks the androgen receptor. That's an anti-androgen. Pretty cool? And that's where we got Yaz and Yasmin from. Now there's a whole story about blood clots with these. If you want, we can get into that. But remember, androgens suppress the estrogen effect. So which of those generations of pills is going to have the least blood clots? 1, 2, 3, 4. Two, absolutely, right? Because it has the highest androgenicity. Its progestin is going to mute the activity of the estrogen. Okay, which one is going to have the highest if you went with that? The one that was an anti-androgen, number 4. And that's what everybody believed. Unfortunately, the data don't support it. But that's what's on label, is a concern, increased concern for blood clots for the third and fourth generations. Okay, and it's minuscule. If it exists, we haven't seen it, but okay. The 5th generation, you haven't seen, any of you, I bet. Has anybody heard of the birth control pill? Yes, please.
Sorry, clarification, you said generation 4 has that highest increase in blood clot?
It would be worried to have the highest risk because it's an anti-androgen. Not only does it, right, not have lower androgens, but it blocks androgens. But to get to a certain point at the level of the liver, what we're seeing is that the estrogen is given free rein, and it's going to have the maximal effect on the liver. And we know that the liver makes a lot of clots. Now, long-term studies with drospirenone have not shown any increased risk compared to the other 2 generations. Maybe the second is slightly safer, but it's not clear. Okay, so if we played with the progestin, what if we played with the estrogen? What if we went to a weaker estrogen instead of being something that can go through the liver 5, 6, 7 times during the day before it's half as strong as it was at the beginning of the day? Maybe if it broke down the first time and you only got a first pass at it, right? And went off to a whole bunch of other compounds that were very, very weak and wouldn't cause an increase in blood clots. Wouldn't that be a way to make pills safer? Because the big one thing we're worried about is blood clots, right, with the pill? And it's all to do with the estrogen. Progestins just don't do that to us, right? So we look to see the interaction between the progestin and the estrogen. Now, could we directly attack the estrogen? What if we went to a weaker estrogen? What if we went to estradiol? And that's what the 5th generation, they found a progestin that was strong enough and controlled the endometrium well enough that a wimpy little estrogen could do it for you. Okay, and that's what Dinogest. You're going to see Dinogest in many other places. It's going to be used for endometriosis. It's actually used because it has anti-angiogenic activity. What does that mean? It blocks the growth of blood vessels. Okay, and can you see every month you get more blood vessels into the endometrium? If you block those, she's not going to lose so much blood at the end of the month. Right. They're using these for metastatic cancers. Because what keeps the growth of the tumor going is that they get new blood vessels. Right? If you treated with this, then the blood vessels wouldn't grow, and the metastases wouldn't grow as fast. Intriguing compound, but incredibly expensive. It's a branded pill, about $100 a month. Does reduce the risk of blood clots, though. And it does reduce menstrual blood loss, as well as Mirena does. So it's pretty cool stuff. But you got a general history. So a patient comes in and she's got acne. Which is the pill you're not going to give her? Which generation?
2.
You got it, right? Somebody who is got bloating, or she's got breast tenderness before her period. Which pill would you give her?
Which would you give her?
What?
Which would you give or which would you
Which one I would give? Somebody who's complaining of fluid retention signs.
Oh, the spironolactone one, number 4.
Number 4, can you see how you can do that? Now, or, right, and she's got acne, 4 would be better. We haven't got comparative studies between the 4 and 3, but we have 3 does work, 4 does work very well. And strangely enough, you'll learn 4 also works. Yaz is also as effective as any other therapy we have for PMDD. We'll come to that. Pretty amazing stuff. But can you play with these a little bit and understand them? Just ballpark. Fine tuning, we can get to different formulations. But 91 different pills we have. And if we can't know all these types of things, but if you have general rules, then we can do that. When we get to contraception, I will. Oops. How did I do that?
Just click on the window button again on the corner over there. The
On
other
the corner?
side. Yeah.
Like down there?
Yeah.
Like where it says.
Boom. There you go.
Okay. All right, potencies you got there. We talked about the estrogens. The first generation is mestranol. It is a pro-drug. And I told you already that 50 of mestranol, which is what the pills have, are equal to 35 to 40. Ethinyl estradiol is the one that's in every single other pill, with the exception of estradiol valerate, which is in that Natassia that you've never heard of. Okay, so here are some of the other progestins that we have and different estrogens that we have. I'm just giving you names so that you can have them. Let's look at combined pills. We talked already that the action hormone, the thing that works in birth control pills, is the progestin. And the one thing that all progestins share as a mechanism of action is thickening the cervical mucus. The wimpiest little progestin to the strongest. They all start with that. And then the question is, how much can they suppress ovulation? Okay. So, and I told you, they block the LH surge and therefore ovulation. They have other impacts that also affect fertility, but they're not nearly as well known and hardly ever on tests. Okay, so estrogen was added to provide cycle control. And why do we have to do this? And I start with a 0.35 milligram norepinephrine and I add estrogen, I've got to bump up the progestin. Why? Talk to me. What? Oh, close, but something else. What is the anchor? The first thing that progestin does? All progestins do what?
Thicken the mucus.
Thicken the cervical mucus. What does estrogen do to cervical mucus? Right?
Okay.
So I've got to have more progestin to keep the estrogen impenetrable and thick. Does that make sense to everybody? Okay. Okay, one other thing you need to know about pills is the formulations. Okay, in the old days, we put in 21 active pills and 7 placebos. We did that so women would bleed because they wanted to bleed. And they needed to bleed in the beginning because the doses were so high that they would walk around feeling like they were pregnant day in and day out, right? You get that much hormone. And to let them know that they weren't pregnant, the period was very helpful. The pregnancy tests we had in those days didn't work until she was 6 weeks pregnant. Okay, and we'll talk about those if you like sometime. So she needed, on average, women had to be 5 days from their last pill before they would bleed, and to get 2 standard deviations of women bleeding, they had to wait 7 days. And honestly, that's where the 21 The problem was that we lowered the doses of the pills, and we forgot to shorten the pill for women. So women didn't get suppressed for so long. So today, as I said, if she takes her last pill on Sunday, she'll start her period on Tuesday. Yes? And when did we lose the ovary? Monday night. So she's recruiting follicles. Can you see that? So to make low-dose pills work and to block unscheduled spotting and bleeding in the next cycle, we shorten the pill for you. So the low-dose pills today, 24 active pills for placebos. That gets every woman going if she's going to. She's going to have a withdrawal bleed. It allows time for that, but it doesn't give the ovary time to wake up and cause mischief for the next cycle. We got better control. Does that make sense? Okay. The multiphasic, as I told you, Natassia, actually it's got it down to 28 active pills and only 2 placebos, but that's something different. Okay. Do women need to bleed? Is there any benefit to bleeding when you're on the pill? What was the purpose of menstrual bleeding? What did we say?
To get rid of the unfertilized.
That's right. Now, did the woman who just took a month of pills want to be pregnant this month? Does she want to be pregnant next month? Maybe, maybe not, but okay. But does she need to clean anything out? No. The historical, did she need to bleed so she knew she wasn't pregnant? Maybe. But a lot of women know. There is absolutely no medical indication for making women bleed. None, and there's no benefit. Is there suffering that comes from it?
Yeah.
Okay. Even though the pill reduces that suffering, there's still suffering. So when you look to see benefits and risks, there's this whole issue as an option. Now I said there's no medical indication. Are there psychological indications? Do we respect that? Absolutely. But can we open the door for women who know better and feel comfortable? Okay, and that's where the extended cycles come from. 4 days of active pills and 7 days of placebos or half-strength pills. So those are extended cycle formulations. Can you see all those differences? So those, in addition to the hormones, is how you use them to take it. Then there are monophasic pills, where every pill is exactly the same, and then they're multiphasic. So that you might start off with a low level of progestin and increase it through the cycle. So you support the endometrium and you keep the estrogen the same. Or could you move them both? And what can you do with those different formulations in different situations? You might be able to help women with different bleeding patterns. Okay?
Sorry, excuse
Please.
me, I'm a bit
You
confused
want me to go back?
about, yes, please. So when, during the cycle, do these women bleed?
On the placebos.
Okay. So for the one that has the 26-2, she's just gonna bleed for 2 days?
No, she starts bleeding.
Or start bleeding?
And that gets to how many days does she bleed, okay? And how you can help her with that. Usually it's significantly less blood loss when a woman is on the pill because the progestin keeps the endometrium thin, right? So there's not as much that builds up that needs to be sloughed off. And interestingly enough, these women on 84/7 build up less than the women who only take it for 21 days. The endometrium thins the longer you take the active pills. People think it all builds up and you'll have the period from hell, and it's actually far less. Okay, can you see? Yes, please. This is good.
So for like the numbers connected to these, would we have to memorize them for the
Oh,
test?
good Lord, no, I'm not gonna do that to you.
Oh.
But I would like you to know about the lower dose pills. You'd like to have a cured placebos.
Okay.
And I'd like you to know that extended cycle gives you 3 months. In fact, they call this seasonal. And honestly, I was on the ad board for this.
Mhm.
And I lectured across the country on these types of things. And it wasn't until I was standing in front of an audience of about 700 people that I finally got the name. She's having her spring period, her summer period, the season. You're kidding. She's an animal for that. And of course, all the comedians got it. As soon as we launched this, did any of you see the Saturday Night Live ad about the woman who had PMS for a whole year because her period wouldn't come down? She's like, and she was brutal. Anyway, they didn't get it, the purpose of this. In fact, she wouldn't be menopause, but it made a good skit. So no.
Okay, cool.
Okay.
Yes.
And I told you why the 7 days though, right?
Mhm.
Because of the delay. Okay. Can you remember these things? We covered them?
Yes.
Yes? I just thought it'd be important. We talked about estrogen hypertrophy in the adipose tissue. Right? Okay. The progestin affects insulin-resistant fluid retention, and then atrophy of the endometrium, and the androgen effects. Okay, here we go. She comes in and she complains of weight gain. And it is during the pills, but it goes away with her period. Estrogen, androgen, progestin. Cyclic weight gain goes away with her period. She noticed that she's been putting on weight. The androgen may be building up her muscle. Are you okay with that? So if you think about, not that she is necessarily putting it on, but that's her perception. Or the distribution, she's been putting it on here, here, and here, that's the estrogen, isn't it? Right, so you might change the pill she's on when you've figured out what it is she's talking about. You haven't noticed any weight gain at all in her, but she's feeling it, and you ask her why, and it's her clothes. Distribution, estrogen, gone. Goes away with my period, progestin. So now you can hurry and change the pill and change the hormones that you've got there to help address her issues and be responsive to her. We talked about lipids, Okay, I'm gonna hand you these and ask you to go download all of this, but these are just a list of things that you absolutely wouldn't give, reasons you would not give women estrogen-containing pills. Okay, things do change, definitely estrogen and progestin change menstrual periods. We talked about it, Andrew. Okay, here we go. 25-year-old woman has been using a low-dose pill. It has, well, not low dose, it has norethindrone, 0.5 milligram, and ethinyl estradiol, 35, for 5 months now. Now, remember, the doses can run up to 1 of norethindrone. She complains of bleeding during the last 3 days of her active pills and into her placebos. She's not missed any pills. What hormone does she need to support her endometrium at the end? Is it estrogen, progesterone, or androgen? Progesterone. So you want to increase her progesterone in her pill, right? But you may not want to do it all month. When does she need it?
At the
At the
end.
end of the cycle. Could you use a triphasic formulation that boosted the progestin at the end of the month? Totally. Can you see why we might have those triphasics? You can individualize to help her with her bleeding and her symptoms. So if you figure out what the problem is, what hormone it is, you can address it once you've got the pills. Not that we're gonna ask you on tests, this is how to make use for it. What if it was done just during the first 2 cycles? What would you tell her? Is her body getting used to the pill? Do we get a fair amount? Okay, and what if she were a teen with bleeding? Ever since I went on this pill, I've been having bleeding. You put her on the pill because her boyfriend was coming back from Iraq. Does this come through your mind, all kinds of things it could be? A good question to ask her, of course, with a teenager, anybody. Are you taking the pill every day? Does it happen? Okay, you get that, but say she's taking the pill. A good question to ask is, when does it happen? Does it happen after sex? And if it happens after sex, what did he bring home with him? Chlamydia. So she's got postcoital bleeding, and that's not gonna be due to the pill. So whenever we get the bleeding, there's so much reflex, it's gotta be the pill. Think of everything else that could be, because you don't wanna miss something else very special. Okay, we talked about estrogen, adverse events, thromboembolism, slight increase in arterial, maybe some blood pressure, the melasma, and changing in the bleeding, and other nocebo effects. What's a nocebo? Has anybody ever heard about that? We've heard about placebo, but it's a nocebo. It's a new word, okay? Oh, this is actually VTE I wanted to show you. Oral contraceptive users. Can you see it is a doubling of the risk in VTE risk when you use an estrogen-containing pill? But it's still far less than pregnancy, and it's a world of difference than the postpartum period. So if you keep her from getting pregnant, are you reducing her risk of VTE? Okay, but if you are worried about VTE, can you give a progestin-only method? Because that's not gonna increase it. Okay, breast cancer, I'm not gonna do that. I'm gonna let you go through this. Drug possibilities, very important. We talked about drug absorption, things are influenced. Don't worry about, this is important. It says in labeling in the pharmacies, you may not know this, pharmacists are required to counsel patients based on labeling. There's so many studies that I've read where they go and they do a secret shopper and they listen to what the pharmacist tells the patient, or they play that they're the patient and they, pretend that they have this problem and they listen to what the pharmacist says. I was like, oh, they conclude, pharmacist is so out of date. We have all these studies that, this isn't true. Like with emergency contraception, Plan B could be beyond 3 days. They just say 3 days. I walk in 4 days, he says too late, okay? He has to say that. He may be the best informed, he may know more than you do, but he's not allowed to tell you, okay? He has to counsel on. So you, as a person who also knows the data, should always buffer the patient from this. So you make a diagnosis of a UTI and you're starting on a birth control pill, okay? And what does he have to tell her? The antibiotics could reduce the effectiveness of the pill, so she should add condoms. Or maybe wait to start her pills on next cycle. so she can get pregnant this cycle. So we know that the prescription you're writing for her does not affect, he may know this, but he has to tell her, because that's on labeling, okay? So you tell her, poor little pharmacist, he has to tell you, okay? We all know it's not true, but it's on labeling, ancient labeling, so he has to tell you. I just want you to not be worried, okay? So when he tells her this, you've inoculated, like she's not gonna worry that you don't know. Whenever you deviate from labeling, always tell her you know what's on labeling, you know that that is applied to her, but it doesn't affect her. You're still making this decision. So it doesn't sound like you don't know what you're talking about, because patients read the labels and their lawyers read the labels, okay? So you said you may be practicing really good medicine, but it's off-label, so you just label it as such, tell her the reasons behind it, and just get rid of a world of problems. Okay, so broad spectrum antibiotics do not affect the efficacy. It may lower serum levels a little bit, but they're still therapeutic. And the way we know this, I can go through the mechanism of why it is. It's second pass, but even people who don't have colons can do really well. If she has continuous vomiting and effectively misses her pills because she vomits them up, okay, can you give other, or say she has a bowel problem? Maybe she's got IBS. Maybe she's had bariatric surgery and lost the part of the colon or the intestines that absorb the drug that you want. Then that's where we turn to a patch or a ring, right? Where we don't have to have GI absorption. Okay, but there are some drugs, and we already know 2 of them, that are going to affect the ability for the pill to work. St. John's wort is one, and the class of anticonvulsants, yes. Okay, and some antiretrovirals that are there. Breeziofulvin and rifampin are 2 antibiotics that do affect. Okay, rifampin used to be just for tuberculosis, but then it went for MRSA too, so you need to know this. You probably aren't going to give breeziofulvin, you don't treat systemic fungal infections very often, okay? But they do, those very potently affect, and you will get subtherapeutic, okay? She got an implant. On phenobarb, she got pregnant. Any surprise there? Okay, after normal delivery, she took normal birth control pills along with her phenobarb. She didn't use the backup method. She got another pregnancy. Are we surprised? Okay, so what would be a good method for her?
The dental intrauterine.
Dental would be good, or an intrauterine? Totally. Excellent. Okay, and hardly anybody knows about drug interactions. Must be humble. You probably know more than most people. That's why it's always good to have you down under. Seizure disorders we talked about. And then these is, look how potent Tegretol is on reducing estrogen and progestin. Are you impressed? Okay, these are do not induce. So Keppra doesn't cause a problem. Clonopine doesn't. Lyrica, Neurontin, all of those, pretty good. Okay, so either go higher on the dose, right, or do some other thing altogether. Lamictal does the other thing. Lamictal levels decrease if they're given as a single agent, but if they're mixed with another one, it doesn't mess with it. Is that just drive you crazy? This is, nobody's going to test you, and I just want you to look up Lamictal when you're giving it with birth control pills. Okay. So clearance, we do St. John's wort, there we go. You're going to have a big deal. Sometimes the best pill is a patch. Okay, we do have one patch and maybe another one coming on the market. This one has higher estrogen levels than with the higher dose pills. It's like a high dose pill for us today. So we still do offer it to people as once a week, but we realized that when we were worried about blood clots, that this potentially could be associated with higher blood clots than typical pills would be. But it does make for easier applications. It doesn't work as well in heavy-set women, but hardly anything does. And the big question is, does it have a higher risk of VTE? And on label, they say it does, so you need to talk to patients about it. And the vaginal ring, yes? Anybody seen those, played with them? This is amazing. Squeeze it between your fingers, show the patients. 1 ring, 1 month. Okay, it's supposed to be in 3 weeks and out for a week, but most people today, and it's off-label but evidence-based, put it in for a month, change it once a month, but put another one right in so you don't have to have a period or bleed. Okay, so extended cycle with this, 1 month, 1 month, 1 month. We've just gotten FDA approval for 1 ring that we would use in 3-week cycles like that. 3 weeks in, 1 week out, but 1 ring will last for a whole year. So she doesn't have to go buy new ones. She just takes that, put it in a holder, rinse it off, and put it back in again when it's time again. So the obvious thing is, can we do extended cycle with that? Well, of course, we have to look into that, but not right now. All right, so are you pretty cool on that? And daily fluctuations, none. Constant levels, and this has area under the curve estrogen half as much as you get with a pill. You don't need as much estrogen when it's always there, right? So you don't have the fluctuations and the swings, it's always there. Progestin is about the same. And cycle control is not matched by anything else. So when you're talking to about a patient, how do you approach it? Do you want to schedule a bleed? If not, then you'll turn to the extended cycle or vaginal rings. What health benefits are you looking for? And we didn't cover these. We will when we get to the methods of birth control. What else can your birth control offer you? You may not know this, but Depo-Provera decreases sickle cell crises by 70%. Okay, an amazing benefit. All right, and if she has anemia, do we want her to bleed as much? All those types of things. She's got fibroids, can we help? Right, so we think of all the other things going on in her life, and what can we add? It's contraception plus whenever you can get it. But you needed to know, okay, this is an anti-progestin, and we'll probably get to this when we get to grandma. Okay, does this give you enough? I think did you shovel enough new stuff in? Yes?
Yeah.
Okay, go play with it a little bit, and it'll be interesting when we come back together again and we go back through the menstrual cycle. I will add a lot more bells and whistles to it, but if you have that basic framework, it'll work. Yes, please.
So like, we don't have any certain things where I can see it. Like, we don't go into much detail because we're gonna get into
Right,
it.
I won't put things like that on the
So,
test.
yeah,
I just want you to know the basics, please. Okay. Did I talk a lot about estrogen and the potential effects, drug-drug interactions, where estrogen works in the body, progestin? Okay. Would it be fair to ask you about the different generations of progestins? In broad strokes, no names, but if I just said by generation, just like we did with the little question thing. Yeah.
but that's as far, like, if you would put names or something.
Oh, I can't expect you to know the names.
I don't know.
I wouldn't expect you to. Seriously, that wouldn't be fair. And then the questions that we had about how Depo or IUDs might work better, because they're working different mechanisms. Because I think mechanism of action is really important in contraception, right? So you can explain it to the patient, and so you can meet her needs. Okay, and why you do a transdermal in somebody with a GI problem, and why you might do a vaginal ring in somebody with psoriasis, right? Because you can't put a patch on. Okay, some skin issue that you had. It's got to be reasonable. And I believe strongly you have the right to challenge questions. We have that mechanism here, right? If you challenge, I'm very open to that. So if I said something wasn't going to be on the test and I tested it, put me side of the head. Okay? Figuratively, please. All right, have a good evening. Thank
You too. No, not all of them. I guess like there's a lot, right? And that's why I was being pretty interested in trying like, dude, how do we?
The ones, first generation, second generation, those